Am I audible? Is there any issues? My video needs to be spotlighted. My video needs to be spotlighted. Okay. Just a minute. Submit for. There are some issues with my iPad, so just let me know if there are any issues with voice or anything. So please let me know. Okay. Okay, all good. So, can I get started? Is there any issues with my echo? Voice is echoing or anything? Okay, fine. So I will get started now. Yes. Okay then. Yes, I will get started. Okay, all right. So, sorry for that late start today because there was some issues with my connectivity and the iPad as well. So that's why I could not come online for a long time. Okay, so that is the reason. So anyway, now it has been sorted out. So we will get started. I think the last topic which I discussed was regarding the murmurs, right? It was about the murmurs, and we had discussed about the systolic murmurs also, correct? We had discussed about systolic murmurs. Did we discuss about this one? The mitral valve, this most common congenital valvular heart disease, I think it was not yet discussed, correct? Correct. Most common congenital valvular heart disease has not yet been discussed, correct? right. Okay, fine. The reason is because, yeah, the PPT is little, okay. Okay, yeah, till aortic stenosis we have discussed. Okay, fine. Okay, right, all right. So we'll get started now. So today the problem is with a little bit of connectivity issue. So I will not be able to see all the screens today. So we will start. I will keep discussing. In any case you had any doubt, you can please put it up in the during the break time. Okay, so I will try to reply to them in the break time or after the session has ended. Okay, because I'm not able to see the screen simultaneously. There is some connectivity issue here. Okay, so we will get started with the most common congenital valvular heart disease. Okay, right. So, congenital valvular heart disease, if you see, there are two different things which you have to remember. One is called congenital heart disease itself. Congenital heart disease, most common congenital heart disease, which is what you must have read in your pediatric session. Most common congenital heart disease. What is that? The most common congenital heart disease overall, it is VSD, ventricular septal defect. That is the overall most common congenital heart disease. Okay, right. Overall most common congenital heart disease is VSD. Okay. However, the question is not congenital heart disease only, it is congenital valvular heart disease. Okay, something associated with the valve. If we talk about VSD, ASD, and all, they are all related to the septum. Okay, now I am specifically asking about valvular heart disease. Okay, the valvular heart disease most commonly is something called MVP. MVP. What is that? Mitral valve prolapse. Mitral valve prolapse. This is the most common congenital valvular heart disease. Okay. Right. It's a condition characterized by an abnormal looking mitral valve. Okay. You see, I am going to put up the picture here. Okay. You see this picture. This is actually the mitral valve prolapse. Can you see the area which is highlighted? This is between the left atrium. This is the left atrium and the left ventricle. And the valve in between is the mitral valve. And can you see, this is the zoomed version of that particular area, okay, where you can see the mitral valve normally should be flat. It should be flat like this, correct? Mitral valve should be flat. This is a normal looking mitral valve. But in prolapse, what is happening? The valve is actually bulging like this. Can you see that? Okay, the valve is dome shaped like this. Okay, this is actually an abnormal looking mitral valve, which is what we call it as the most common congenital valvular heart disease called mitral valve prolapse. It goes by another name also called as Barlow's disease. It is also called Barlow's disease. It's also called Barlow's disease. Okay, it's also called Barlow's disease. Okay, now some of you may be having a doubt that if it is a congenital condition, it should have started in the childhood itself. However, this condition is very different in that it is going to start in the adult age group only. Typically, if they want to give you a clinical scenario question, they will give you the age like this: young females. That is the time this condition is going to present with. Young females. Somewhere in the 20s or 30s, females will have a presentation with mitral valve prolapse. So that is a point to be noted. It is a condition involving young females. Okay, so the presentation age is little late. That is why we are discussing in the adult medicine part. That's all. Okay. So why do you think this mitral valve is prolapsing? What is the cause for that? Okay, of course, it's a congenital condition, but the cause is that myxomatous degeneration of the valve. It is myxomatous degeneration. Of the valve. You must have studied about different types of degeneration in your pathology classes, correct? In your pathology classes, so many types of degeneration must have been studied. One of that is myxomatous degeneration. That is what exactly happens in mitral valve to cause the abnormal looking mitral valve. That is the point. Okay. And the reason for this myxomatous degeneration is usually it's a congenital condition. By birth itself, it is present. However, it has got certain association, and these associations are important MCQ questions for your exams. Okay, right? And these associations are in the form of conditions which usually involve some connective tissue problem, some connective tissue disorder, because myxomatous degeneration also is something related to the connective tissue, like the smooth muscles, all those connective tissues. So this is also associated with other connective tissue disorders. Whenever I say connective tissue disorders, what condition comes to your mind? Right? Something involving the connective tissue. I will give you the clue. It is something related to collagen defects. Yes, it could be number one, Marfan syndrome. Number one is Marfan syndrome. Number one is Marfan syndrome. Number two is Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. So two important conditions wherein there is a problem with the connective tissue, like the collagen. Okay, that is where you have the problem. So Marfan syndrome and Ehlers-Danlos syndrome. Two important associations for this particular condition. Okay. Now, what are the features of this condition? Remember, I told you the presentation is an adult age group, but this condition is usually asymptomatic. As such, patients will not present with any complaints. Usually, it is asymptomatic. Okay. So, it's something like they come to the clinic for some other reason. For example, it may be due to fever. They are presenting for evaluation, or some other problem, it is not at all related to the heart problem itself, they present to the clinic, they present with some unrelated condition. At that time, when you examine the patients, you will notice certain characteristic findings. See, what happens? Number one finding, this will be the clue in your exam. This finding will always be present. See, I will just take you back here. Okay, this is a picture of the mitral valve prolapse. You can see that mitral valve is not normally present. It is something like a floppy ball. Okay, floppy. Floppy means it is not having enough strength. So what happens when it is opening also it's a problem, when it is closing also it's a problem. It won't close properly or open properly. That is the main thing. But it is not like regurgitation or stenosis. No, it is not like regurgitation or stenosis. It would be something like a problem in the exact closure of the mitral valve. Okay, that is a point which I want you to remember. And how does it present? Okay, I will tell you like this. See, this is the diagrammatic representation. Left atrium and left ventricle. This is the mitral valve. Okay. Normally, when is the mitral valve expected to close? Is it during systole or diastole? It is during systole only. Why? Because only during systole, the blood has to flow from the left ventricle into the aorta. For that purpose, during systole, the mitral valve should be completely closed. Okay, normally a mitral valve should be closed like this. Okay, flat like this. However, in this situation, it is not going to close. It is going to close exactly like this, what I have shown in the picture. How it is going to close? It will be closing suddenly. It is something like suddenly it will be closing and it would be something like this. Okay. So what happens when it is suddenly closing? Okay. When it is suddenly closing during the systole time, it creates a sound called as a clicking sound. Okay. And this clicking sound is the characteristic finding in case of this mitral valve prolapse. Okay, so when does that clicking sound occur? It occurs during systole due to the abnormal closure of this prolapsed mitral valve. Okay, right? And this sound is what we call clicking. And what is the name of this sound? It is called mid-systolic click. That is a characteristic presentation of this particular condition. Mid-systolic click. Able to follow. It is mid-systolic click. So click refers to the sudden closure of the prolapsed mitral valve during the time of systole. Okay. Next thing, in the late stages, what can happen is, late stage means I'm talking about when they become older adults, okay, right? Not young adults, old adults, like for example, 50 years, 60 years. At that time, what can happen is, some portion of the valve may not be closed fully. So during the time of systole, after the click sound, what can happen is some amount of blood can regurgitate back from the left ventricle into the left atrium. So it more sort of a regurgitation finding, but that would occur in the late stages only, not in the early stage. So what happens when the blood is flowing from the left ventricle into left atrium during systole? What will be produced? Yes, of course, murmur will be produced, but it is not going to be pan-systolic murmur. Only after the clicking sound. When does the clicking sound occur? In the mid portion of the systole. After the mid systole only, the murmur will be produced, or what I am going to write as late systolic murmur. It creates late systolic murmur. Okay, so the finding would be something like this. If I draw like this, S1, S2, then S1, the portion between S1 and S2 is called as the systole, and here you will get the click. That is what I call it as mid-systolic click. Okay, mid-systolic click. And after that, in late stages, the murmur would start like this. This is what we call late systolic murmur. This would be the set of findings in case of mitral valve prolapse. That is a point to be noted. And mitral valve prolapse, you don't need to treat this condition. Very, very important, because I told you, usually the patients are asymptomatic. So you don't need to treat this condition at all. Okay, you don't need to treat this condition. It's a benign condition. Okay, so there are few important catchwords whenever they give you a question about mitral valve prolapse. One, presentation would be in a young female, and usually they are asymptomatic. And what is the characteristic finding which is noted on clinical examination? It is always mid-systolic click. Mid-systolic click. These are the characteristic things which you should remember regarding the mitral valve prolapse, which is the most common congenital valvular heart disease. Okay, right. Now, I described that condition because that is also one of the causes of systolic murmurs. Okay, that is also one of the causes of systolic murmurs. I hope all of you can quickly recollect what all conditions I told you for systolic murmurs. What are the conditions I told you for systolic murmurs? If you can recollect, no need to write this, you must have written it already. One was mitral regurgitation. Another one was, of course, tricuspid regurgitation also, not common, but mitral regurgitation is a common condition. Any stenosis can cause systolic murmur. Any stenosis can cause systolic murmur. Yes, of course, aortic stenosis and pulmonary stenosis, aortic stenosis and pulmonary stenosis. Any other condition in the stenosis group itself, I told you, tetralogy of Fallot. One more, HOCM, hypertrophic obstructive cardiomyopathy. Any other condition with the systolic murmur, I told you, VSD. What is that? Ventricular septal defect. Okay, if you see all these, MR, TR, as well as VSD, what type of systolic murmur do they get? They get pan-systolic murmur. Whereas AR, PS, tetralogy of Fallot, and HOCM, what type of murmur you get? You get what? Ejection systolic murmur. Ejection systolic murmur. And now I have told you MVP, that is mitral valve prolapse. What type of murmur you get in mitral valve prolapse? Late systolic murmur. Late systolic murmur. These are all the important examples of murmurs which are in the category of this systolic murmurs. Okay, any issues? Just a minute. Yes, correct. Okay, you are typing the answers. Very correct. Okay, right? All these are important examples of systolic murmurs which we have discussed in the last class. To that list of systolic murmurs, I have added now mitral valve prolapse. That's all. Okay. Now moving on to the next category, continuous murmur. As the name suggests, continuous means you have both systolic as well as diastolic murmurs. And I think the best example of the continuous murmur, which you must have already learned in your pediatric sessions, which will be related to something called a congenital heart disease. What is a congenital heart disease where you get a classical continuous murmur? Yes, it is PDA. What is that? Patent ductus arteriosus. Patent ductus arteriosus. This is a classical example of the continuous murmur which you get. Okay, right? And what is a description of that continuous murmur in patent ductus arteriosus, which I am sure most of you should be remembering? It's one of the loud murmurs. What is the characteristic? It's called machinery murmur. It is called as a machine-like murmur or a machinery murmur. It's a machine-like murmur or a machinery murmur. Okay, right? Yes, it's a machine-like murmur or a patent ductus arteriosus murmur. Okay, right. Okay, that is number one. Number two, anything else? Any other condition? There is also one more condition, which is like a congenital heart disease only, but there will be a lot of collateral formation in that condition. Collateral formation in that condition. Any of you know which congenital heart disease you get lot of collaterals? It's a condition characterized by narrowing of aorta, and due to that, there is a collateral formation. Which condition is that? Yes, I am giving you clues to make you think about that condition. Characterized by narrowing of aorta, followed by that there will be collateral formation. Yes, correct. It's a case of coarctation of aorta. Okay, very correct. It's a case of coarctation of aorta. Coarctation of aorta. Okay, coarctation of aorta. Okay, right? And coarctation of aorta, what is happening? Collateral vessels will be formed. I think you can recollect from your pediatric sessions. And these collateral vessels are the ones which are going to create this continuous murmur. Can anybody name what is that collateral which is formed in a case of a coarctation of aorta? Which artery is that? Yes, it is nothing but the enlarged intercostal artery. It is an intercostal artery. It is the intercostal arteries which are enlarged and form a collateral circulation. And when the blood passes through that enlarged intercostal arteries, you get a continuous murmur. Okay, that is the point. So one is PDA, next one is coarctation of aorta. Third, see, these two are the main conditions. Other things and all not very important, just you can quickly note it. Third is something called venous hum. Venous hum, which is noted in young children. Okay, as a part of hyperdynamic circulation, it is noted. You just remember venous hum, that is enough. Fourth, I think in your OBG classes, you might have heard about this. Okay, pregnant ladies, they have an increased flow in the chest area at the level of this internal mammary arteries. Okay, increased flow in the internal mammary arteries, and that creates a sound when you auscultate in the chest area. What is that called? During pregnancy, there is a continuous murmur here in the chest area. What do you call that? You call this as a mammary souffle. It is called as a mammary souffle. And that mammary souffle represents what? Increased flow in which artery? Mammary souffle increased flow in the internal mammary artery. Internal mammary artery. Okay, internal mammary artery. That is the point. It's an increased flow in the internal mammary artery. That is what you have to remember. Okay, internal mammary artery. Okay, right? Yes, yes, internal mammary artery. Now, fifth one. Fifth one is something called, just for the exam purpose of only, just like a point you can remember, you don't need to this thing, right? It is something called RSOV, which is called ruptured sinus of Valsalva. Ruptured sinus of Valsalva. Okay, these are the typical examples of a continuous murmur. Okay, these are typical examples of the continuous murmur. Okay, right. Yes. All these are important things which I want you to remember for examples of the continuous murmur. Clear? Okay. First two things are something which are important for exam. Usually the question asked for in this category is typical example of continuous murmur is PD. Okay, right. So with that, I have completed all the murmurs which can be encountered in different type of heart diseases. In different types of heart diseases. Okay? Are you able to follow this? Right. So this is about the murmurs part which I want you to remember. With that, we move on to the next section of heart disease. See, today there are two important sections in heart diseases which needs to be focused upon. One is about the ECG abnormalities, and second would be related to myocardial infarction or something called coronary artery disease. Okay, so two important categories which I am going to discuss in detail. Other things will be like small categories like hypertension, infective endocarditis, something like pericardial diseases. All those things will be there. Okay, right? All those things will be described. Along with that, we have two major topics for today's discussion. In fact, these are the two major areas from where many questions have been asked in the past from heart disease for your exams. Okay, right? And I hope that ECG sessions have been completed, right? In your physiology classes, have they completed the ECG sessions? Has it been completed? ECG sessions have been completed in your physiology classes. ECGs. Can anybody comment on this? Is ECG completed in your physiology classes? Last time you said physiology classes were not over. So can you tell if it is completed or not? Okay, ECG sessions have been taken. Okay, I think that is a good thing to know because I can skip the initial part of it, like leads and all, I can skip it, right? I don't think I need to discuss it in detail because in your physiology classes, they must have told in great detail. Okay, right? So what I will be doing is, I'll be telling you a brief introduction to the ECG leads, and then straight away I will go on to the abnormalities which you should know importantly for your exams. Okay. But this one full page is related to basics of ECG only. I'll be brushing through them, but I hope you can recollect from your physiology classes as well. Okay, right? What we follow typically is called the 12 lead ECG. Okay, it's called as a 12 lead ECG, where you have 3 limb leads, 3 augmented leads, and 6 chest leads. The limb leads are defined like this: 1, 2, and 3. And the limb leads were the first type of leads used to record the ECG, which is what we call it as the Einthoven leads. Okay, I think you can recollect what is the Einthoven leads refer to. Einthoven leads is something like this. It is something like a triangular area like this, which we represent on the right side as the right upper limb, left side as the left upper limb. I am writing LL, left upper limb, and the lower one is what? Left foot or right foot? It is left foot, very important. The right foot is like neutral. Right foot is like the neutral. Otherwise, there will be continuous activity inside the body, right? So, right foot is kept as a neutral. Right limb, left upper limb, and left foot are taken for this recording purposes. And every lead is something like this. Here is the lead 1. Here is the lead 1. And lead 1 has got a negative point and a positive point. Negative point is the right upper limb. Positive point is the left upper limb. It is a negative and positive areas. And always remember, whenever we pass an electric current, it always flows from the left, negative to positive or positive to negative. It always flows from negative to positive. So this will be the direction in the lead number 1. From the right limb towards the left upper limb. Okay. What about lead 2? Lead 2 is here. Lead 2 is here. Lead 2 is here. What is that? It is something between the right limb and the left foot, where right limb is the negative point and left limb is the is the positive point. So how does the current flow through the lead 2? It would be something like this, right? From the right upper limb to the left foot. Okay. Now for lead 3, any comments? Where is the lead 3? The lead 3 is here. The lead 3 is here. Here, the left upper limb is the negative polarity and left foot is the positive polarity. So in the lead 3, how the electric current would flow? It is something like this. From the left upper limb to the left foot area. So this is the orientation of the 3 leads which you should remember. Okay, right? The concept is very simple. You have a negative polarity and a positive polarity, and the current will always flow from the negative polarity to the positive polarity area. And whenever there is a current flow, it will create a potential difference which will be shown in the EG like deflections. I think all of you know about this. Whenever there is a positive flow, it creates a upward deflection. Whenever there is a negative flow, it creates a downward deflection on an EG. When there is no flow, it will create a flat line on the EG. I think you can recollect the basics which you have learned in your physiology classes, right? Positive deflection is upward, negative deflection is downward deflection. No flow at all, reflected as a flat line. That is what we usually study for EG. Okay, this is about the limb leads, which is the Einthoven leads. Augmented leads are called as the Goldberger's lead. Any of you know what is the name of this augmented leads? Right, I think you can recollect it. You must have studied that also. Everything starts with A. A for augmented. What is that? ABR, ABL, and ABF. Okay. And this is what is the Goldberger's lead or the augmented leads. You can see here. You can see the name. It's called Goldberger leads. Wherein what we try to do is we keep one positive polarity, that is correct. But instead of keeping a negative polarity as one area, we keep it as a common point between two areas. Okay. And by keeping this negative polarity as a common point between two areas, we are actually augmenting the signals which we are getting from the leads. For example, you see here in AVR, okay, first area, this AVR, the positive polarity is a right upper limb. Can you see that? The positive polarity is a right upper limb. And negative polarity is the other two areas. Can you see? Left upper limb and left foot. And in between is what you get as the negative polarity. So it is something between the left arm and the left foot. Can you see that? I'm writing for AVR. Positive polarity is the right arm, which is here. Negative polarity is between left arm and left foot. That means in between this area is where you are having the negative polarity. By keeping an area of negative polarity in between the two limbs, we are actually augmenting the output from the limbs. So that is why it's called augmented limb leads. Okay. Similarly, for AVL, you can see it is a left arm, which is the positive polarity, and negative polarity will be between these two. AVR, that is the right arm, and the left foot. That's all. AVF, you can see the positive polarity is the left foot. So negative polarity will be between the left upper limb and the right upper limb, this area. Are you able to follow this? Okay. This is what is the meaning of augmented leads or the Goldberger's lead. Okay. Then finally we come to the chest leads. Chest leads will be remembered like this: V1 to V6. Okay, V1 to V6. And I think all of you can recollect from this picture. This is how the chest leads would look like. Can you see that? V1, V2 and V6 laterally. Okay, so from medial to lateral, you are going like this. Okay, and every chest leads look at the heart in different areas. For example, what is that? Yes. What is that? 1 minute. Yes, it is looking at the anterior part of the heart. Very correct. It is looking at the front of the heart. It is not only looking at the front of the heart, it's also looking at the sides of the heart, lateral areas of the heart also. Can you see that? Front of the heart and the sides of the heart. Okay, if you see these V1 to V4, can you see that? V1 to V4, they are looking at the front of the heart only. So that is why they are called anterior limb leads. Are you able to follow this? Okay, anterior limb leads. In fact, if you see V1 and V2, V1 and V2, they are actually looking at the septum. Can you see that? Interventricular septum. Interventricular septum. So that is why the common name for this V1 to V4, it's not just called anterior limb leads, they're also called anteroseptal. Anteroseptal. That means they're looking at the anterior part of the heart as well as the septum of the heart. Okay, that is what we call anteroseptal leads. septum, specifically V1 and V2, but V1 to V4 generally anterior limb leads. That's what we have to remember. Then what are the lateral? Can you see that V5 and V6 are looking at the lateral surface of the heart? So that's why they are called left lateral or simply called lateral chest leads. Okay, that is what you have to remember. Okay, so V1 to V6. That's what you have to remember. Okay, right? V1 to V6. That's the point to be noted. Okay, right? So these are the different type of leads which you should know about. Any idea why you should know the leads for your exam purposes? I think they might have told you. You can check for the rate and rhythm and all in different leads. That's all okay. But for the further discussion purposes, what I want you to remember is whenever you get some changes in the leads, I'm typically talking about the situation of MI. What is that? Myocardial infarction. Myocardial infarction. You can actually note not only the changes of myocardial infarction, you can also notice which artery is actually undergoing occlusion in a myocardial infarction to result in the EEG changes. Okay, right? I think this has been discussed. Has this been discussed? What is the artery localization using this ECG leads? Has it been discussed? Artery localization using ECG leads. Okay, right? It's a quick review only. What is that? See, whenever we talk about the heart, there are three major arteries which are supplying the heart. Okay, we know right and left is okay, but other than that, just a minute, I'll take out the picture. One minute. Okay, right. I think the picture is not here, but you can just recollect, right? Right and left coronary artery, and left coronary artery, two more division. What is that? Left anterior descending as well as left circumflex artery. Okay, right? So basically it is RAD, sorry, right coronary artery, sorry, RCA, right, RCA, right coronary artery, and LCA, that is the left coronary artery, and left coronary artery is divided into two further things, namely the left anterior descending and left circumflex artery. Okay, now you try to tell me few things. Right coronary artery is supplying which part of the heart? Right coronary artery is supplying the which part of the heart? It mainly supplies the right ventricle, and right ventricle forms the which surface of the heart? Superior surface, inferior surface, or the lateral surface? Which surface is the right ventricle forming? It is the inferior surface. So can I put it like this? Right coronary artery is related to the inferior area of the heart, and if it is occluded, what we call that? We call it inferior wall MI. So right coronary artery, the localization is related to inferior part of the heart problem. Okay, right. Then we have left anterior descending artery, which is going to supply the anterior parts, not only anterior, it is also supplying the septal areas. So anteroseptal portions of the heart. Anteroseptal portions of the heart. Okay. Anteroseptal portions of the heart. Okay. Anteroseptal portions of the heart. Left circumflex artery, any idea? It is going to supply the lateral surface of the heart. It is going to supply the lateral surface of the heart. Going to supply the lateral surface of the heart. You're able to follow this. Okay? Right. And any idea out of these three arteries, which is the most commonly affected artery in case of a myocardial infarction? Most commonly affected artery. Just a minute. You can type in your answers. Which is the most commonly affected artery in case of myocardial infarction? One minute. That is the problem. Okay. The most commonly affected artery? Yes, it is LAD. Most commonly affected artery is the LAD, left anterior descending artery. And generally, myocardial infarction is more common in a male compared to female. So that is why this artery causes more death in the males. So that is why this artery is also called as what? It's also called as widowmaker's artery. It's also called widowmaker's artery. Okay, right. Widowmaker's artery. Okay. All right. Are able to follow? Now, what we will do is, I will be explaining that later, and there's something which you can also have a look at it during your, during the break time, you can look at it. If these arteries are going to be affected, in which leads you will get the changes? What are the leads you will get the changes when each of the arteries affected? For example, RC is affected, which leads will show the changes. LAD is affected, which lead will show the changes, and LC is affected, which lead will show the changes. This is something for you to work upon. During the break time, you can have a look at it. You can also correlate with these pictures and try to tell me the answers later. Okay, right? As of now, I am not discussing that. I will come back to this discussion. Maybe after the initial break time, I will ask you this question. Okay, right? Is everything clear till this time? We are just discussing about the usual things only, right? Whatever you have discussed only, it's a discussion of basics in ECG. That's all. Okay, right? And this is very important for medicine discussion because in a case of MI, we will try to tell which artery is affected based on which leads are showing the changes. That is why I want you to know about this as an initial introduction. Okay, right. Now continuing with few other basics of this ECG. You can see from the next page. Can you see? This is how the ECG paper would look like. And you can see in the ECG paper, there will be large squares and the small squares. I'm not going into the details and all, but just quickly see one small square, that is this area. One small square. Sorry, one small square. What is the time for that small square? It represents 0.04 seconds, or it is also called as how much? 40 milliseconds, correct. Okay, 40 milliseconds or 0.04 seconds. And this is the one large square. Can you see that? This is one large square area. One large square is basically 5 small squares, correct? One large square is basically 5 small squares. So 5 into 0.04, which is 0.2 seconds. Okay, right? 0.2 seconds or 200 milliseconds. That's all. Okay, right? This is what you need to remember. Okay, I think better is you can remember in terms of seconds. Okay, milliseconds also you can remember, that is fine. But I think in terms of seconds, if you remember, it is easier to follow. That is what I will be using for majority of the discussions further. Okay, right? So one small square and one large square. Okay. Corresponding to the duration, because whenever we say something like an interval or what is the duration of this QRS complex like that, we always say in terms of seconds. So that's why you have to remember. Next, we move on to something called waves in the ECG. Okay, right? The few basic waves are P waves, then QRS waves, which is what we call complex as QRS complex, and one more is the T wave, right? So can you recollect what is the P wave representing? The P wave is representing, it's a positive deflection, right? What is it representing? Depolarization or repolarization? It is depolarization only. Which depolarization? Atrial depolarization. It represents atrial depolarization. Don't forget. Okay? It represents atrial depolarization. And what is the QRS representing? QRS is representing ventricular depolarization. Ventricular depolarization. Ventricular depolarization. Then what does T represent? T is representing ventricular, yes, ventricular repolarization. Ventricular repolarization. Okay, right? So P wave is atrial depolarization, QRS is ventricular depolarization, and T wave is ventricular repolarization. Then where is the atrial repolarization? Any comments? I told you atrial depolarization, that is fine. Then where is atrial repolarization? Any idea? See, atrial repolarization also occurs, but that atrial repolarization occurs during the time of QRS. Okay, so what I'm trying to say, atrial repolarization will not produce any waves because it is overshadowed by ventricular depolarization or the QRS complex. So if somebody asks you the question, where is the time in the ECG where atrial repolarization is occurring, you will answer it is occurring at the time of ventricular depolarization and it is overshadowed by the QRS complex. That is why I am not able to see any separate wave for atrial repolarization. Okay, this should be kept in mind. Okay, fine. So these are the important waves which you should remember. Then we have to remember two things. Okay, one is called as a interval, another one is called as a segment. Anybody wants to comment on what is the meaning of segment? What is the meaning of a segment? Segment is something wherein you have flat lines in the ECG. Segment is an area where you have flat lines in the ECG. Flat lines means what did I tell you? Is it any electrical activity or no electrical activity? It is simply areas of no electrical activity. Areas of no electrical activity. Right? Areas of no electrical activity. And there are two segments as you can see in this particular ECG. What are the two segments? I've already marked that. Number one is this one. What is that? PR segment. Can you see? It's a flat area. This area. Can you see that? It's a flat area here. Can you see that? This is the PR segment. What is the second segment? The second segment is the ST segment, which is also another flat area here. Can you see that? Okay, so two segments are there. Actually, segments, you don't need to know it in detail. I am just marking them. I'm not, I'm not expanding them. I'm just writing the names. That's all. One is a PR segment from the end of the P wave to the beginning of the QRS complex. Another one is the ST segment, which is end of the QRS segment or the QRS wave to the beginning of the T wave. That is called as a ST segment. Are you able to follow this? Okay, so these are the segments. Then next one is something which is important. What is that? Something called intervals. Something called as a intervals. This is important for your exams. Intervals. Any of you know what is an interval? Interval is something like a combination of a wave and segment. Wave plus segment. Wave plus segment is what we call interval. Wave plus segment is what we call interval. And there are three important intervals which you should remember. Three important intervals which you should remember. Any of you know the intervals? What are the intervals you know? Yes? What are the intervals you know? One is PR interval. Second one is called RR interval. Third one is called QT interval. So there are three important intervals. Okay. First is this one, PR interval. I am writing here PR interval. Okay. PR interval. What is this PR interval? Can you see that in the image also? This is the PR interval. I'm writing here. I'll just write like this. Roman numerals like this. One is a PR interval. What is that? It is from the beginning of the, please note this, beginning of the P wave to the beginning of the QRS complex. Can you see that? Beginning of the P wave to the beginning of QRS complex is what is the PR interval. Okay, beginning of the P wave to the beginning of the QRS complex. And can anybody comment what is this PR interval representing? It is a time taken for what? What is the PR interval representing? What is the PR interval representing? Anybody? What is the PR interval representing? I'm just waiting for an answer. What is the PR interval indicating or representing? It's a time taken between the atrial depolarization and the ventricular depolarization. Okay. Or it is a time, if you want to simply put it, taken for the electrical impulse to travel from the atrium to the ventricle. Are you able to understand? Are you able to understand this? See, P wave is atrial depolarization. QRS is ventricular depolarization. PR interval, something it starts from the P wave to the beginning of QRS, meaning from the time taken for atrial depolarization to ventricular depolarization, or if I want to put it in simple words, it's the time taken for the impulses to travel from the atrium to the ventricles. That's all. Okay, right. Now, I'm not going to write all of them because I'm short of spaces which must have been already discussed in your physiology classes. I'm going to write only one more thing. What is that? What is the normal duration of the PR interval? Simple question. What is the normal duration of the PR interval? It is 0.12 to 0.2 seconds. Or in other words, roughly 3 to 5 small squares. Are you able to follow? It is roughly 3 to 5 small squares. That is what is the PR interval. 3 to 5 small squares, roughly. Okay, right? And can you correlate? This area is the PR interval from the beginning of the P wave to the beginning of the QRS complex. Okay. Then we move on to the next wave. Oh, sorry, next interval. What is that? QT interval. Okay, it is QT interval. QT interval. QT interval. Can you see where is the QT interval? Where is the QT interval? It is from here. What is that? Beginning of the Q wave. Can you see that this is the QT interval? See here, this is the QT interval. It is from the beginning of the Q wave. Can you see that? It is from the beginning of the Q wave to the end of T waves. Can you see that? Beginning of the Q wave to the end of T wave. This area. Beginning of the Q wave to the end of T wave. Okay. And QT interval, please remember, it is not a fixed interval. It depends on the heart rate. Very important. It depends on the heart rate. Depends on the heart rate. Depends on the heart rate. That is why we always call this interval as not just QT interval. We call it QTC. C is something like corrected. Any idea what is it corrected for? It is corrected for the heart rate. Depending on the heart rate, we will calculate the QT interval. QT is dependent on the heart rate. That is a point to be noted. Now, how do you calculate the heart rate? Any idea how do you calculate the heart rate? I'll come to this. I'll come to the QT shortly. Any idea how do you calculate the heart rate? Heart rate is calculated based on what? Heart rate is calculated based on another interval. What is that interval? R interval. R interval. Okay. It is R interval. R interval, can you see here? It is between one R wave. Can you see that? This is one R wave and this is the next R wave. The gap between the two R waves, that is, this is what we call it as the RR interval. And that RR interval is a representation of the heart rate. Any idea how do we calculate the heart rate based on this RR interval? Any idea? RR interval, I will write one thing. It is used to calculate heart rate. It is used to calculate the heart rate. Heart rate. Or I am going to write as HR. Heart rate. Any idea how is heart rate calculated? There are so many ways by which we do this, but this is the easiest way for you to remember. It is 1500 divided by the number of small squares between 2 RR. Okay, between 2 R's, what is the number of small square? This is how the heart rate is calculated. This is how the heart rate is calculated. 1500 divided by number of small squares between 2 R's. That is how it is usually calculated. Okay, please write that. Please write it. Okay. Is it written? Okay, so heart rate is something like 1500 divided by number of small squares between 2 RR. That is the point to be noted, between the 2 RR. Clear? Okay. Now, going back to this QTC, I told you QTC is something which is dependent on the heart rate, right? And heart rate is calculated with the help of RR interval. So this QTC, any idea how it is calculated? QTC, the corrected QT interval, it is calculated like this. QT divided by the root of RR interval. QT divided by the root of RR interval. That's what you have to remember. Okay. And any idea how much is the roughly the QT value? Roughly the QT value? Any idea how much is roughly the QT value? It is around, yes? Any comments? What is the normal QT value or normal QT interval? Roughly around 0.4 seconds. 0.4 seconds. It is roughly around 0.4 seconds. Okay, right? So these are some of the important numbers which you should remember. Okay, these are some of the important numbers which you should remember. I hope you are able to follow this. Okay, right. Just a quick recap of whatever I have discussed till this time. Basically, in a ECG, we have to look at three things. One is the waves, another one is the segments, and third one is the intervals. Waves of P waves, QRS complex, and T waves. Okay, and P wave represent the atrial repolarization, QRS ventricular depolarization, and T wave ventricular repolarization. All right. Okay. Atrial repolarization is not seen because it is submerged in the QRS complex. Then we have something called segments. Segments are the flat lines, and there are two segments which you should know. One is the PR segment, another one is a ST segment. Okay, they don't have much of a significance except in few cases of MRI, which I'm going to tell you. Third is very important, which is the intervals. Intervals are a combination of waves plus segments. Okay, right? And the three important intervals, PR interval represents the time taken for the travel of impulses from the atrium to the ventricles. That is the PR interval. QT interval is something which is depending on the heart rate. Okay, and the heart rate is calculated with the help of RR intervals, where heart rate is typically calculated like heart rate is equal to 1500 divided by number of small squares between the two R's. Are able to follow, right? Clear? Okay, so that is all about the basics of ECG which you should remember. Now we move on to something called the abnormalities in the ECG. This is where you get lots and lots of questions. So many questions have been asked previously in the section of this rate and rhythm abnormalities, which I'm going to describe about. Okay, we will go a little slow here. Okay, we will just try to remember each and everything in a detailed way. Okay, actually, there are like 4 or 5 rhythms only which are commonly asked for your exams. Of course, in myocardial infarction also I will be telling you changes in the ECG, but generally 4 or 5 rhythms is what you should be basically knowing about. Okay, fine. Let us start the discussion first with something called bradycardia. What is the normal heart rate? You see, bradycardia is a condition characterized by decrease in the heart rate, correct? Decrease in the heart rate. Okay. Normal heart rate, I think all of you know, is around 72 per minute. It is like a range, like around 70 to 80 per minute. That is what is the range. But normal heart rate we say as 72 per minute. And when will you is there any issues? I think there is some issue with the video. 1 minute. Just give me a minute. Just a minute. Is it okay now? Just a minute. Is it fine? Sorry, there was a small interruption. Okay, I think that now it is okay. Fine, fine, right. Okay, okay. We'll just continue. Okay, right. So we were discussing about the sorry. We were discussing about the rate and rhythm abnormalities. Okay, so here bradycardia refers to a condition where the heart rate is less than 60 per minute. Okay. Now, can anybody tell me a normal situation where heart rate is actually less? A normal person, but the heart rate can be less. It is usually seen in athletes. It is usually seen in athletes. Okay. If you look at their resting heart rate, it is actually less. See, I think all of you know heart rate is controlled by sympathetic and parasympathetic activities. Sympathetic activity actually increases the heart rate. Parasympathetic activity actually decreases the heart rate. And parasympathetic is something related to the vagus nerve. I think all of you know about it. Okay. Something related to the vagus nerve. And whenever there is a high vagal tone, it actually decreases the heart rate. And in athletes, you notice a high vagal tone, which is the reason for decreased heart rate. I hope you are able to follow this, right? So it's a normal condition wherein athletes are having a decreased heart rate. Okay, that is number one. Number two, in patients who are having hypothyroidism also, the heart rate is decreased. Hypothyroidism, heart rate is decreased. And third is patients on some drugs can decrease the heart rate. Can any of you think of any drugs which can decrease the heart rate? Yes, beta blockers, heart rate will be decreased. Patients who are taking CCBs, that is a calcium channel blockers, also the heart rate is decreased. So these are common conditions where you get bradycardia. Remember, for a normal bradycardia, that is in athletes or in patients who are not having any problems, you don't actually need to treat that condition. But some patients, bradycardia can cause problem, like for example, decreased cardiac output. Patient can have something like syncopes, fainting episodes and all. For them, if it is symptomatic bradycardia, you have to treat all of them. Okay, any idea for symptomatic bradycardia, what is the treatment we give to increase the heart rate? Of course, I told you, vagus activity is going to decrease the heart rate, or cholinergic activity is going to decrease the heart rate. So you have to give something like an anticholinergic. So what will I give? I am going to give atropine in the treatment. That's all. I am going to prescribe atropine. Atropine will be the treatment in case of symptomatic bradycardia. Please make a note of this. This is important. Atropine is for symptomatic bradycardia. This is to increase the heart rate. Okay. Are you able to follow this? Okay. So that's about bradycardia, which you should remember. Okay. Next, in this category of decreased conduction, there is something called heart blocks. What is the literal meaning of heart blocks? Heart blocks are something related to the electrical conduction inside the heart. Something related to electrical conduction inside the heart. Electrical conduction is due to something called as a conducting system, SA node, AV node, bundle of His, all those things. So I am going to write heart blocks is a condition due to some problem in the conducting system of the heart. It's a problem in the conducting system of the heart. Conducting system of the heart. So where could be the problem? It is somewhere in this conducting system which I am going to draw like this. SA node, AV node, and from the AV node you have this bundle office. You have the bundle office, and this bundle office will be followed by this fibers. What are these fibers I am drawing now? Purkinje fibers. Purkinje fibers. If you have a problem in any of this, you call it as a heart block condition. Okay, any problem in this conducting system of the heart is what we call the heart blocks. Okay, right. And depending on where is the problem, you have different types of heart blocks, which we call as first degree heart block, second degree heart block, and third degree heart block. Okay, and this is a ECG rhythm abnormality which you should definitely know about. Okay, so let us see from the next page. Let us see from the next page. Okay, right? So this is what it is. Just give me a minute. There is some fluctuation happening. Just a minute. Just a minute. Okay, so it seems to be fine now. So let us start. Yes. So yes. Comment on this. This is the first degree heart block. Any comments on this about the first degree heart block? See, first of all, whenever you are looking at a ECG strip, okay, you have to first start with the basics. Okay, see whether all the waves or all the waves are normal or not. Is there any problem in that waves or the segments like that? You have to look at. So here I am going to write the waves. This is the P wave. This is the QRS. And this is the T wave. Correct? Here also we have P wave, QRS, T wave. Same thing here. P wave, QRS, and T wave. Then what is the problem? It is normal, correct? But there is some issue in this ECG. What is that issue? Look at the PR interval. Look at the PR interval. I told you how is the PR interval calculated? PR interval calculated from the beginning of the T wave to the beginning of the QRS. Okay, I think just a minute. But from the beginning of the PRS to the beginning of the QRS complex. Normally, what is a PR interval? I told you it is 3 to 5 small squares. Let us see how many small squares are here. Okay, you see here, I am looking at 5 small squares here, and one more is here, 4 small squares. So it is something like 9 small squares are there. Okay, is it a normal PR interval? Normal PR interval should be only 3 to 5 small squares. Here it is more than 5 small squares, like 8 or 9 small squares are noted. Similarly, here also, can you see how many small squares are there from the beginning of P wave? Sorry, from the beginning of the P wave to the beginning of the QRS complex. How many? 4 plus 4, 8. That is also increased here from the beginning of the P wave to the beginning of the QRS. How much? 1, 2, 3. 3 plus 5, 8. Again, it is 8 small squares. Okay, so definitely what I am seeing in this is there is a increase in the PR interval. Increase in the PR interval. This is what is called first degree heart block. This is what is called first degree heart block, where you have an increased PR interval. What is the simple meaning? Simple meaning is there is a increased time taken for the conduction of the impulse from the atrium to the ventricle. What is the gatekeeper between the atrium and the ventricle for the passage of impulses? What is the gatekeeper between the atrium and ventricle for the passage of impulses? Of course, SA node generates the impulses. I am asking what is the gatekeeper between the atrium and the ventricle? It is a AV node. Can I say like this? Through the AV node, the impulses are getting delayed. So that is why there is a big gap between the P wave and the onset of QRS complex. Okay. So I am going to write, it simply represents AV nodal delay. It simply represents AV nodal delay. That is actually what is first degree heart block. Okay, first degree heart block is characterized by increased PR interval, which is nothing but a representation of AV nodal delay. Are you able to follow this? Clear? Okay. And what are the conditions where you get first degree heart block? This is also an important question which you should remember. One, it could be normally seen in patients who are older, or it's an aging process. Number one, it could be an aging process. Number one. Number two, it is encountered in digoxin therapy. You must have heard about digoxin therapy, which can cause a lot of heart blocks. One of the heart blocks is first degree heart block, so it can be a part of digoxin therapy. Third is it can be seen in a rheumatic fever. I think we have discussed about the rheumatic fever, Jones criteria. Okay, can you recollect that? Jones criteria we have already discussed. And in the Jones criteria, if you can remember, one of the minor criteria was first degree heart block in the form of increased PR interval. Do you remember that? I told you Jones criteria, everything like TP like that you can remember. I told you in that one of the P is related to PR interval which is prolonged or increased. Are you able to follow this? Everybody? Clear everyone? Okay, so this is the first degree heart block which is characterized by increased PR interval. Okay. Then we move on to the second degree heart block. In second degree heart block, please remember there are two types. Okay, both these are second degree heart blocks. It's of two types. Okay, and we call them as like this, Mobitz types. Okay, we call them as Mobitz type. Mobitz type. This is called Mobitz type 1. This is called Mobitz type 2. Okay, Mobitz type 1 or Mobitz type 2. Let us start with the Mobitz type 1. Okay, what is the problem here? What is that? Again, look at the waves. This is the P wave, QRS complex, and T wave. P wave, QRS complex, T wave. P wave, QRS complex, T wave, and here there is a P wave, but there is no QRS complex and no T wave. Are you able to understand? So what is happening? Is one of the complex is not even conducted from the atrium to the ventricle. That is what you are thinking. Are you able to understand? Are you able to follow this? After three complexes, the fourth QRS complex is absent. That is what you are seeing. Second thing you also have to look at is the something else is striking here. Anybody wants to comment on this? Comment on this, which I am marking now. What is that? It is a PR interval. Can you see what is happening? PR interval, it was okay here. It is prolonged here. It is more prolonged here. And here, it is not no PR interval itself. What is the meaning? There is a progressive increase in the PR interval, and at one point, there is no QRS complex occurring after the P wave itself. Alright, or I am going to write like this. There is a progressive increase. Can you see that? There is a progressive increase in the PR interval. Are you able to follow? There is a progressive increase in the PR interval. Followed by that, there is a loss of QRS itself. Or in other words, one wave is dropped. One wave is dropped. Are you able to follow this? Okay. So, if I want to put it in terms of electrical conduction, what I can say is the conduction through the AV node is progressively delayed, and at one stage, no impulse from the atrium is getting conducted to the ventricles. This is what we call second degree heart block, Mobitz type 1. This is the description of that. What is that? Progressive increase in the PR interval followed by a dropped QRS complex. This is what we call it as second degree heart block, Mobitz type 1. It is also called as Wenckebach phenomenon. This is an important word for you to remember. It's called Wenckebach phenomenon. Mobitz type 1 is also called Wenckebach phenomenon. I hope we are able to follow this. Progressive increase in the PR interval followed by a missed QRS or a dropped QRS. This is what we call second degree heart block, Mobitz type 1 or Wenckebach phenomenon. Moving on to the next one. What is the next one? Second degree AV block. This is type 2 Mobitz. Type 2 Mobitz, second degree AV block. What is that? Here you can see P wave, QRS, P wave, QRS and T wave. Here P wave, but no QRS and no T wave. Here P wave, QRS, T wave. Next one, P wave, no QRS, no T wave. Again P wave, QRS and T wave. What is the meaning? For every 2 P wave, can you see? Here is 2 P wave. For every 2 P wave, there is only 1 QRS. Can you see that? Same thing here also. These are 2 P waves. But for that 2 P waves, you are having only 1 QRS. Are you able to follow this? So it is something like a fixed ratio. There is a drop in the QRS complex. What is the meaning? What is the ratio here? It is something like 2:1. What is the meaning? For 2 P waves, there is only 1 QRS. Okay? For 2 P waves, there is only 1 QRS. This is also mixed conduction only, but it is like a fixed block. 2:1, 3:1, something like that. Okay, right? And comment on the PR interval. Comment on the PR interval. Any comments? This is the PR interval here. There is no PR here, so I'm going to look at it here. How many PR intervals are there? How many boxes are there? 1, 2, 3, 4. Here 1, 2, 3, 4. 4 boxes are covered in the PR interval. Is it a normal PR interval or abnormal PR interval? It is absolutely normal PR interval. So normal PR interval. Normal PR interval. However, there is a missed conduction. There is a missed conduction. And this missed conduction is a fixed conduction, not random. It's a fixed conduction. Like for example, 2:1 or 3:1, something like that. Okay. In the particular example which I have given is 2:1. Some other examples can be 3:1 also possible. So this is second degree heart block, Mobitz type 2, wherein there is a normal PR interval, but there is a fixed and missed conduction in the form of 2:1 or 3:1. Are you able to understand this? Everybody able to understand this? Okay, right? Are you able to follow? Right? Okay, very correct. This is what you have to remember. So, Mobitz type 1 is characterized by progressive increase in the PR interval followed by a loss of QRS. Whereas Mobitz type 2 is characterized by fixed PR interval, not normal PR interval, but there is a missed conduction in a fixed ratio like 2:1 or 3:1. Okay, I hope you're able to follow this. Then we move on to the last one. What is the last one? Last one is third degree Hunt block. Third degree Hunt block, you see here, it looks like a P wave, but there is no QRS. But here it looks like a QRS, something like that, or T wave, something like P wave, or query it is P wave, or query it's a T wave. This is like a QRS. This is query P wave, query T wave. I am not able to make a definite relation between the P wave and the QRS complex. Are you able to follow this? Are you able to follow? Are you able to make any definite relation between the P wave and the QRS? No. In fact, we are not even able to make out which is P wave and which is a T wave. So it is full of chaos, means it is fully disorganized ECG. What is that? There is no relation between P wave and QRS. What do you call this? This is what we call AV dissociation. AV dissociation. What is the meaning? Atrium is having a depolarization on its own. Ventricle is having a depolarization on its own, and there is no proper relation between the atrial and ventricular depolarization. This is what we call complete AV dissociation. Complete AV dissociation, and this is what we call third degree heart block. Third degree heart block. Are you able to follow this? This is what we call it as a third degree heart block. Okay, complete misunderstanding between the atrium and the ventricle. We are not able to find a definite relation between the P wave and the QRS complex. This is what we call complete atrioventricular dissociation or third degree heart block. Are you able to follow? So let us just quickly revise all the important heart blocks. First degree heart block is characterized by increase in the PR interval. That's all. P wave QRS relation is normal. There is no problem with that. Only problem in the first degree heart block is there is an increased PR interval. That's all. That is first degree heart block. Second degree heart block is characterized by two types, Mobitz type 1 and Mobitz type 2. Mobitz type 1 is characterized by progressive increase in the PR interval followed by a loss of QRS complex. Mobitz type 2 is characterized by normal PR interval, but there is a fixed block in the form of 2:1 or 3:1. That's what you have to remember. And third degree heart block is a complete heart block where you don't have any relation between P wave and QRS, or there is no correlation between the atrial and ventricular depolarization. That is what we call complete AV dissociation or the third degree heart block. I hope you are able to follow this. Everyone able to follow this, right? Okay. Now, obviously, you can see more the degree of heart block, more is the problem. Okay. And usually what happens is that first degree heart block, okay, this one, first degree heart block, as well as the second degree Morbitz type 1. Usually the patients are asymptomatic. Usually the patients are asymptomatic. So you actually don't need to treat these two conditions, like first degree heart block as well as second degree Morbitz type 1 also, you don't need to treat it. However, Morbitz type 2, that is this one, as well as third degree heart block, patient will be symptomatic. Like for example, fainting episodes can be there, decreased cardiac output can be there. So these patients, they need treatment. They need treatment. Any idea which treatment do we advise for this patient? Any idea which treatment do we advise for this patient? We need to regularize the heart rhythm. How can you do that? How can you do that? You have to implant a pacemaker. Pacemaker insertion is required. Pacemaker insertion is required. You must have heard about pacemakers. These pacemakers will regularize the heart rhythm. Okay, that is what is recommended for these two group of patients. Okay, are you able to follow this? Everybody able to follow till this point of time? Clear? Okay, very good. So that is about the first set of heart rhythm abnormalities which I want to discuss related to decreased heart rate or the bradycardia. Okay, fine. Next we move on to the increased heart rate rhythm for what we call tachycardia. See, tachycardia means a heart rate of more than 100 per minute. It can be seen in so many conditions, even normal conditions. Sorry, not normal. Yes, even normal condition, like for example, pregnancy, you get an increased heart rate. Whenever you are doing an exercise, obviously the heart rate will be increased due to sympathetic activity. What are the pathological conditions? I told you hypothyroidism for bradycardia. So here it will be hyperthyroidism for tachycardia. Hyperthyroidism for tachycardia. Anything else? Even fever, you can get tachycardia. Anemia, you get tachycardia. So many conditions you can get tachycardia. And even in the condition of shock, you might have heard in your surgery class, right? For example, a patient who's having road traffic accident and he went into shock. What is the early stage of shock called? Early stage of shock is called as a compensated shock. Compensated shock, where you will have increased heart rate. Okay, tachycardia, where you have increased heart rate, right? So these are the conditions wherein you have tachycardia as well characterized by increase in the heart rate of more than 100 per minute, right? Okay. Then we are going to look at something called tachyarrhythmia. What is the meaning of tachyarrhythmia? Here, not only the heart rate is increased, arrhythmia refers to an abnormal rhythm also. Arrhythmia refers to an abnormal rhythm. Abnormal rhythm also. That's what you have to remember. Abnormal rhythm. Tachyarrhythmia refers to an abnormal rhythm associated with increased heart rate. And we try to divide this tachyarrhythmias into two areas. One is called atrial tachyarrhythmia, or what we call supraventricular. Supraventricular means above the ventricles. Above the ventricle, what is that? Atrium means it's called atrial or supraventricular tachyarrhythmia. One more is called ventricular tachyarrhythmia, where the problem is originating inside the ventricles. Okay, right? We are going to discuss them in detail, but I will give you a small introduction as to how do we differentiate in a patient with tachyarrhythmia into ventricular or supraventricular tachyarrhythmia. It is based on the QRS duration. QRS duration. So what you will see is, you will see the QRS complex and you will see the width of the QRS complex. See, this is the QRS complex which you're talking about, right? Like this. This is the QRS complex which you're talking about. Any idea what is the normal duration of the QRS complex? How many small squares are there in the QRS complex? Any idea? How many small squares are there in the QRS complex? It is 3 small squares. It is 3 small squares are there in the QRS complex. Or in other words, it is 0.12 seconds. It is 0.12 seconds. This is the number of or the duration of the QRS complex. 3 small squares or 0.12 seconds. And based on this QRS duration only, we try to divide into atrial or ventricular QRS complexes or ventricular tachyarrhythmias. In atrial tachyarrhythmias, what will happen to the QRS? It would be narrow QRS. Narrow QRS, meaning it would be less than 3 small squares. Please remember, it is less than 3 small squares. Okay, and these are the different examples of narrow complex or supraventricular tachyarrhythmias. I have divided into regular and irregular types. You can have a look at it. We are going to discuss them in detail next. Then we have ventricular tachyarrhythmias on the other side, which is characterized by wide QRS complex. Wide QRS. Wide QRS means more than 3 small squares. Can any of you tell me any examples of this ventricular tachyarrhythmias? Any idea? Any examples of ventricular tachyarrhythmias? One is VF. What is that? Ventricular fibrillation. One is ventricular fibrillation. Any other thing? Number two, VT. What is VT? Ventricular tachycardia. Ventricular tachycardia. These are two examples of ventricular tachyarrhythmias. Okay. Are you able to follow this? So just listen. We divide the tachyarrhythmias into two categories based on the duration of QRS. Wide QRS is ventricular tachyarrhythmias. Narrow QRS complex is atrial tachyarrhythmias or supraventricular tachyarrhythmias. We are going to start the discussion with the narrow QRS complex or supraventricular tachyarrhythmias. Okay, right? We will start the discussion next. Yes, we can have a short break now. Have a look at the names. Okay, I'm going to discuss that. I'm going to discuss only about these from the next one. At the time is around 11:30 now. We'll have a 15 minutes break. And in the meanwhile, I asked you to look at one question. What was that? Localization of the ECG leads based on the artery input. That is this area. You try to look at this area also. Maybe after the break, I will start with this question and then we'll move on to the discussion of tachyarrhythmias. Okay. So I'm going to give the break now, 15 minutes, and then we will start again. All right. See some of the answers. Yes. See, if it is something like this, okay, right? I have seen answers for. Yeah, so we'll get started now. Yeah, so we'll get started now. Everything is fine. Can I start the session? Okay, right. So you can tell me for this answers for the question which I had asked before the break. So what are the the leads which will be affected in different types of this MI? That's what is the question I had asked. And if you're ready with the answer, one more moment, just a moment. Mm, 1 minute. Yeah. Okay, you can tell me. Yes. See, if it is something like this, okay, right? I have seen some of the answers. Okay. Correct. Yes, yes. Nice. Okay, very good. Yes, Dr. Sai has got it correct. Okay, very correct. Yeah, I have seen few of the answers. Yes, correct. All are correct only. So I hope all of you have looked at it also regarding the things. I'm going to write like this. It is very, very simple. Okay. If you look at the, see, I think the chest leads are very clear, right? B1 to B6. I think that part is very, very clear. We need to collaborate a little bit with the limb leads also. So it is something like this. The heart is like this. Okay, the heart is like this. Okay, and we have the leads which are looking at the heart from different directions. For example, if I say the lateral area, okay, the lateral area, what are the leads which are looking at the heart from the lateral side? You just try to correlate. What is that? Can you see the lead one, which is this area, is actually looking at the heart from the lateral side? That is lead one. Not only that, this lead also. What is that?
AVL is also looking at the heart from the lateral side. Okay, so I'm going to put it like this. For lateral, we have lead 1 as well as lead AVL. Along with that, what are the two chest leads which are looking at the heart laterally? V5 and V6. Are you able to follow? All these are looking at the heart laterally. Then what are the leads which are looking at the heart from the anterior aspect? See, this is the anterior aspect. Oh, sorry, this is the inferior axis. Sorry, I'm sorry for that. This is the inferior axis. What are the heart which is looking at, what are the areas, what are the chest leads? Not chest leads, what are the limb leads which are looking at the heart from the inferior side? What are they? You can see here. AVF is there, which is looking at the inferior surface of the heart. What are the other two in the limb leads? What is this? This positive is for what? Lead 2 as well as lead 3. So I am going to write like this: lead 2, lead 3 as well as AVF is looking at the heart inferiorly. Okay, looking at the heart inferiorly. Then what is the other limb leads? AVR. Okay, AVR. Where is it looking at the heart? AVR is looking at the heart in the opposite direction. AVR. Now this is a special point to note because compared to all other limb leads, if you look at the AVR alone, all the leads will be inverted. All the leads would be in the reverse direction. Have you noticed that? Okay, I don't have the ECG now to show you that, but if you look at a usual ECG description, AVR alone, you will see all the polarity getting reversed because it is looking at the heart in an opposite direction. Remember, the orientation of the heart is towards the left side, right? But this AVR is oriented towards the right side. Okay, that is why all the tracings in the ECG are actually inverted, sort of inverted in AVR. I hope you can follow that. Okay, it is inverted in AVR. So that is why for our categorization purpose, we will never look at the AVR lead findings. Okay, we will concentrate on all the other leads. So now you can tell me quickly about different areas which are going to be affected. What is it? What are the ones which are going to be in our right coronary artery? See, right coronary artery means inferior. Inferior means what did I tell you? Lead 2, lead 3, as well as AVF. That's what you have to remember. Lead 2, lead 3, and AVF. Anteroseptal is for the what? The chest leads only. What are the chest leads? V1, 2, V4. These are the chest leads. Left circumflex is for the lateral artery, lateral side of the heart. What are the things which are looking at the lateral side of the heart? I have already included. What is that? V5, V6, lead 1, as well as AVL. Okay, so depending on which leads are showing the changes, you can actually infer what is the area or what is the artery which is undergoing occlusion to cause myocardial infarction. What is the commonest artery which is affected? It is the left anterior descending artery. So what are the leads? You are going to commonly see the changes. It will be in V1 to V4. So this will be the common area where you will see the changes in the ECG. Where you will see the changes in the ECG, right? V1 to V4. Are you able to follow this? V1 to V4. Is it clear till now? Everybody able to follow what I am trying to tell you? I am just trying to correlate with whatever things we have already learned with the description. That's all. Okay. I'm just trying to correlate with the chest leads as well as the limb leads in different areas of the heart. You will get an abnormality. I hope you are able to follow till this time. Clear. Okay. So with that, we will move on to the next part of discussion ECG, which will be related to the tachyarrhythmias. Okay. It is related to the tachyarrhythmias. You can see two things I have written. One is the regular as well as the irregular tachyarrhythmias. What are the characteristics of supraventricular tachyarrhythmias? They are narrow QRS complex. We are talking about the QRS complex, which are narrow. Narrow means definition less than 3 small squares. Okay, I hope you can follow this. We were discussing this before the break. Okay, now they are divided into two types based on the rhythm: regular rhythm as well as irregular rhythm. Okay, right? We are going to see the ECG measures, but first description is based on the regular or irregular rhythm. In regular rhythms, we have 3 important things. Out of this, these 2 are ones important for exam: PSVT and atrial flutter. What is PSVT? It is paroxysmal. You write the expansion. I will provide the details later. Okay, paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia, right? PSVT. Paroxysmal supraventricular tachycardia, PSVT. Atrial flutter and one more is junction tachycardia. Just to give you a rough idea, all these 3 are regular rhythms. Okay, whenever you see the ECG tracing, you will notice tachyarrhythmia, but the rhythm will be very regular. That is what I'm trying to tell you. Okay, right? Now look at the other side, irregular. There are 2: atrial fibrillation and multifocal atrial tachycardia. For your exams, the only thing which you should know about in the irregular category would be atrial fibrillation. That's what you are going to remember. We'll be discussing all these things in detail. Just to give you an idea about how would be the heart rate in each of these situations. Heart rate. How would be the heart rate appearing to be in each of these situations? Obviously, it is going to be tachycardia. It is going to be more than 100. But just to give a rough idea, in case of heart rate will be something around 150 to 250 per minute. Rough numbers I'm just providing, these are not exact. For PSVT, it would be 150 to 250 per minute. Atrial flutter, it will be more than that. 250 to 400 per minute will be the heart rate. Whereas in case of atrial fibrillation, it will be even more. Any idea how much is the heart rate? 400 to 600 per minute. Highest heart rate will be noted in atrial fibrillation. That's what you have to remember. Okay, just a rough number. For example, if your clinical scenario question is starting like this and they are mentioning like this in the recording, in the monitor, you are noticing the heart rate of 400, 500, something like that. You can try to categorize them. That is what I am trying to tell you. Okay, right? So 3 names, don't forget in this category. One would be PSVT, next one would be atrial flutter, and third one is atrial fibrillation. Now, any idea out of these 3, which we are going to discuss in detail, which is the most common sustained arrhythmia? It is already written. What is that? This is the most common sustained arrhythmia. This is very, very important MCQ question. Okay, most common tachyarrhythmia. Most common tachyarrhythmia is atrial fibrillation. And I think last year exam, even the year before that, in 2021 also, we had questions from atrial fibrillation. It's supposed to be the most common sustained arrhythmia in clinical practice. That's what you have to remember. Okay. And first of all, what is it? It's an irregular rhythm. Don't forget, it's an irregular rhythm. Whereas on the other side, we have atrial flutter, which is a regular rhythm. Okay, it's a regular rhythm. Now, first, let us try to understand what is atrial fibrillation. Any idea? Fibrillation is something like heart is actually not beating. Heart is fibrillating. Fibrillating is something like tremor, something like this. Something like a tremor. The heart is actually not beating properly, but it is like fibrillating or having a tremor-like movement. And why this tremor-like movement occurs? It is something like this. See, suppose I draw the heart like this. This is the right atrium. What is the pacemaker of the heart? Where does the heart impulses originate from? The heart impulse originates from this area in the right atrium. What is that? AV node. From there, it has to go to the, sorry, not AV, SA node, sorry, SA node. And from there, it has to go to the AV node, and then it has to go to the all the other areas. Okay, right? Normally, there's only one pacemaker which will initiate the impulses in our heart. That's what you all know about. Suppose I say that there are so many pacemakers, not pacemakers, so many areas called foci, each of which generate one impulses. Think like this. All of them are generating one impulses. What will happen? There will be so many impulses going from the atrium to the ventricle. That is why, can you see, I was mentioning that the heart rate is increased so much to 400 to 600. Why? Because every area is generating one impulse. This is what we call ectopic foci. How many ectopic foci? Not one ectopic foci. Multiple ectopic foci are present. Multiple ectopic foci are present in the left atrium. Can you see that? It is in the left atrium of the heart where multiple ectopic foci are present. And that is why you can see there's a very, very high heart rate noted in this situation. I've already provided you the number. It's somewhere around 400 to 600 would be the heart rate noted in case of atrial fibrillation. So basic problem in atrial fibrillation is multiple ectopic foci present in the heart on the left atrium. So in addition to our SA node, there are so many areas which are producing lot of impulses. That is why the heart rate is increased very, very high number to a very high number. Are you able to follow this? This is the basic pathology in case of atrial fibrillation. Okay, right? And there are multiple associations for this particular atrial fibrillation also. One most common is RHD. What is that? Rheumatic heart disease. And in the rheumatic heart disease category, the most common association is for mitral stenosis. Please remember, it is for mitral stenosis. It is for the mitral stenosis. Okay, right? It is for mitral stenosis. That is the number one and the most common association. Number two, thyrotoxicosis. Thyrotoxicosis. Number two is the thyrotoxicosis or hyperthyroidism condition can also have. Number three was one of your recent MCQ questions. What is that? Alcohol intoxication can also result in this particular association. Alcohol intoxication. If you don't have spaces, you can write it in the next page also. There are a lot of spaces there. What is the name of this condition called? Alcohol intoxication, wherein a patient takes a lot of alcohol in a short period of time, something like binge drinking. That time, the problems can occur. Any idea? What is that called? See, usually when they go on a holiday, okay, they don't have any restriction, so they take a lot of alcohol, and that can precipitate this condition also. What is it called? It's called holiday heart syndrome. It is called holiday heart syndrome. Holiday heart syndrome. Don't forget this. This is important. It's called holiday heart syndrome. Okay, it's called holiday heart syndrome. Okay, so this is association for this rheumatic heart disease. Sorry, not rheumatic heart disease, for atrial fibrillation. Okay, right? So one of the reason question is alcohol intoxication causing arrhythmia, which is called holiday heart syndrome. So just make a note of it. So when the heart rate is so high, what do you think is the most common feature in this particular patient? What do you think would be the feature in this patient? Simple question. What do you think would be the feature? The patient will complain of palpitation. Something like the patient is able to perceive or feel his own heartbeat. That is what we call palpitation. That is the most common feature of this particular condition. Able to follow? This is the most common feature of this particular condition, the form of palpitations which are noted. Okay, right. Now, going back to the pathology area, I told you there are multiple ectopic foci producing so much of impulses inside the heart. Now, when the heart is beating, do you think it is a regular beating or an irregular beating? It will be a very irregular beating. That's what I have mentioned also. It's a very irregular rhythm. And because of this irregular beating inside the heart, there will be a lot of clot formation. There will be a lot of clots. I think you can easily understand because the circulation inside the heart is not going to be smooth because of irregular activity inside the heart. The circulation is not going to be smooth. And because of irregular circulation, a lot of clot will be formed inside the heart. And this clot can go to different parts of the body and it can cause what? Systemic embolism. It can cause thromboembolism. And it can result in occlusion of the different areas of the heart. Causing what problem? Thromboembolism causes what problem? It can cause infarction. It can cause infarction in the heart. Infarction in the brain, infarction in the spleen areas. So many areas in the organs, it can cause infarction. Renal infarction can occur. So the complication, the main complication of this condition is multiple clots are found inside the heart, which is going to different parts of the body. Or in other words, I'm going to write this as systemic thromboembolism. Systemic thromboembolism. And this systemic thromboembolism is going to result in clot causing occlusion, or in other words, it causes infarction. This is going to cause infarction in the body. Are you able to understand this? So this is the main complication of this particular condition of atrial fibrillation, which you should remember in mind. Okay, I will come to this point little later also, and I'm going to tell you about the treatment. Okay, so how do you think you are going to base your treatment on? Okay, the treatment will be based on the hemodynamic stability of the patient. Hemodynamic stability of the patient. Patient could be stable or unstable. First, let me put up the ECG finding. Can you see this ECG finding? Very classical. Very classical. What is the ECG finding you are seeing here? Any comments? Anybody? What is the ECG finding in this condition? First one we are focusing on is atrial fibrillation only. What is your number one thinking? Definitely there is tachycardia. That's why the waves are very close by. So there is tachycardia. Okay, so there is definitely tachycardia. Second thing, in this tachycardia situation, you have to divide it into ventricular or supraventricular. How do you divide into ventricular, supraventricular? You are going to look at the QRS complex. You are going to look at the QRS complex. Can you see? This is the QRS complex. Can you see? How many boxes are there in the QRS complex? Only 2 small squares are included. So what is this? Is it a narrow QRS or a wide QRS? Definitely this is narrow QRS. That is my number one observation. Number 2, it's the regular rhythm or irregular rhythm. Definitely it's an irregular rhythm. In the irregular rhythm, the commonest condition would be atrial fibrillation. Are you able to understand this? See, whenever you look at the ECG, you have to think like this only. First, it's a narrow QRS complex. Number 2, it's an irregular rhythm. Very obvious, correct? You see the next one, atrial flutter, that is looking like more regular, correct? This is definitely irregular. So irregular and narrow QRS complex are the 2 things which will strike my mind when I look at the ECG. Second thing, look at this area which I'm going to highlight. All these areas. What are these areas? These are the areas of P waves. Is it looking like a normal P wave? Our first impression would be something like it's an absent P wave. It's something like an absent P wave. See, P wave should have a definite outline like this. This should be the normal looking P wave, right? Normal P wave should look like this. Is it looking like that here? No. It is something like there are multiple broken waves like this. Can you see that? There will be multiple broken waves like this. What does that multiple broken wave represent? Multiple broken wave represents the multiple ectopic foci inside the heart. Can you see that? Multiple ectopic foci inside the heart creates multiple irregular small waves like this. This irregular waves is what we call fibrillatory waves. This is what we call fibrillatory waves, or we can remember by an alphabet F. F wave. This is what we call F wave. Okay, right? So these are the 3 characteristic findings which I want you to remember from this ECG. One is narrow QRS. Second, it's an irregular rhythm. Third, there is no regular P wave. Here you are having an irregular fibrillatory F wave. F wave. That is what we call F wave. I hope you are able to follow this. These are the 3 important findings which you notice in case of atrial fibrillation. I hope till this point it is clear. That is the characteristic ECG finding in case of this particular condition. Okay, right. So now coming to the treatment part. Any comments on the treatment? See, basically, if it is a stable patient, that means the patient is only complaining of palpitation. Heart rate is high, that's okay, but he's complaining of palpitation. Only that's all. He's otherwise conscious. He's otherwise stable. His blood pressure is stable. All these things are okay. Only thing, heart rate is high and he's complaining of palpitation. And he is able to talk normally also. then we call that patient as a stable patient. Simple. For a stable patient, you have to give drug treatment. Very, very simple. Okay. Whereas if the patient is unstable, that means his BP is dropping. He's not conscious or he's not able to be oriented normally, something like that. We call it as hemodynamically unstable patient. And for hemodynamically unstable patient, what do you provide? Something like this, pads over the chest, and then you press, and that will deliver the shock. Shock treatment has to be advised for an unstable patient. Are you able to understand this? Right? Are you able to follow? For a stable patient, it should be drug treatment. For an unstable patient, it should be shock administration. I hope you are able to follow this. Now, you can tell me from your pharmacology classes, what is the drug to decrease the heart rate? Basically, we want to decrease the heart rate and stabilize this patient, correct? And stabilize the heart rate, sorry. Okay. So, what is the drug to decrease the heart rate in a patient with atrial fibrillation? In fact, most of the tachyarrhythmias we give the drug. What is that? Beta blockers. Beta blockers are recommended. Very correct. Beta blockers are recommended. Okay. This is for a stable patient. We give a drug treatment to decrease the heart rate. Second thing, don't forget, what is the other problem? I told you, thromboembolism, infarction can occur. So what you should do to decrease the clot formation? You have to give anticoagulant also to these patients. Anticoagulants also to these patients. Can you give a warfarin here? Can you give a warfarin? You can't give warfarin. Why? Because warfarin is an oral anticoagulant. It will take time to act. In an emergency situation, we cannot give warfarin. So what do we do? We give something like low molecular weight heparin. But compared to low molecular weight heparin, another group of drugs is found to be very useful in this situation. Something called DPI. What is this? It is a direct thrombin inhibitors. Direct thrombin inhibitors. Any names comes to your mind whenever I say direct thrombin inhibitor? There are so many names, but one important for exam which you should know about is dabigatran. It is dabigatran. Okay, it is dabigatran. That's what you have to remember. Okay, this is a direct thrombin inhibitor for management in case of this anticoagulant treatment for a patient with atrial fibrillation in order to decrease the occurrence of thromboembolism. That's all. Are you able to follow this? So two things. One is beta blockers to control the heart rate. Second, direct thrombin inhibitors to decrease the occurrence of clot formation. I hope you're able to follow this. Okay, right. Then next one is for an unstable patient. Unstable patient means patients who are having hemodynamic instability like decreased blood pressure and all, unconscious patient like that. For them, we have to deliver a shock. And I think all of you know about this with the defibrillator. We are going to give that shock. And this is a situation where we have to synchronize the heart rhythm and deliver the shock. So this is called as, you don't need to know the details, something like this, synchronized cardioversion. This is called synchronized cardioversion. This is called as a synchronized cardioversion. What are we synchronizing with? We are synchronizing the shock with the R wave of the patient. That is what is called synchronized cardioversion. Okay. You don't need to know more about this. You just need to press that equipment and you have to press that sync button. That will actually automatically sync with the R wave and then will deliver the shock. Okay. So please make a note of it. The complete name is called synchronized cardioversion. It's called synchronized cardioversion. That is a complete name. Okay. Please make a note of this. Okay. Fine. So that is about treatment of a patient who is having a atrial fibrillation. Okay. Now, this atrial fibrillation, something can occur in multiple times. Okay, multiple times. So if I ask you, in a patient who's having multiple episodes of atrial fibrillation, which drug can be used for prophylaxis? Which drug can be used for prophylaxis? Any comments? Any idea which drug can be used for prophylaxis to decrease the heart rate in the patient? It is amiodarone. Amiodarone is used for prophylaxis. Amiodarone is used for the prophylaxis. Amiodarone is used for prophylaxis. And with amiodarone also, if there is no control, then what is the next thing I have to go for? I have to go for is destruction of all those ectopic foci in the heart, which is what we call radio ablation. It is called radio ablation of the ectopic foci is recommended. Radio ablation of the ectopic foci is recommended. Are you able to follow this? Okay. So remember, for a patient who is having multiple attacks, you give amiodarone, and with amiodarone also there is no relief. You have to go for radio ablation of the ectopic foci. Pacemaker will be for heart block condition. This is not pacemaker. This is for tachyarrhythmia where we go for radio ablation of the ectopic foci. Right? Okay. See, I am saying absent P wave. It is not exactly absent P wave, but the P wave is replaced by multiple irregular waves. So in an ECG, it appears as if there is a P wave, it is absent. Actually, P wave is not absent. P wave is irregular. And P wave normally should be a single wave. This is an irregular looking P wave where there are multiple small waves like this. That is why I'm naming the P wave as F wave. In the correct sense, it is not absent P wave. That's what I'm trying to tell you. It's something like a modified or an irregular P wave, which is broken into multiple parts. That's what I'm calling that P wave as a F wave here. Okay. All right. So that is about the discussion of atrial fibrillation, which is supposed to be the most common tachyarrhythmia, which you should know about, or most common arrhythmia itself. Then we move on to the next condition. What is the next condition? Atrial flutter. What is the point about atrial flutter? I told you it's a regular rhythm. Why regular rhythm? It is something like this. Suppose I'm drawing the heart like this. Right atrium. We have the SA node. Okay. In this particular condition, we have only one ectopic foci. Okay, right? From one ectopic foci, you will see multiple impulses which are generated. So this is a condition characterized by single ectopic focus. Single ectopic focus. That is why, can you see how is the rhythm? It's a regular rhythm. But from that single ectopic foci, multiple discharges are noted. Can you see that? It is not producing only one impulse. It is producing multiple impulses. That is why, what are you expecting the rhythm to be? You are expecting the rhythm to be regular because there is only one ectopic foci. Next thing, how are you expecting the heart rate? Of course, heart rate will be increased. That is true. But will it be like a fibrillation where I have 400 to 600 heart rate per minute? No, it will be less heart rate only because there is only one ectopic foci. So that's why, can you see what I have written? Atrial flutter. What is the heart rate I have written? 250 to 400 per minute. Whereas for atrial fibrillation, it is multiple ectopic foci. That's why I am writing as 400 to 600 per minute. Are you able to understand? Everybody able to understand this? Okay, right. And do you think here there will be clot formation or no clot formation? It is a regular rhythm, so there is no clot formation. So there is no risk of thromboembolism in this particular patient. I hope you are able to follow this. Here also, the feature would be patient will present with palpitation. And most of the times, please remember, the patient would be a stable patient. So what do you think is the treatment I'm going to give for this patient? I am going to just give beta blockers. I am just going to give beta blockers. Of course, most of the time, patient will be stable. That's why I'm limiting only to the beta blockers. Okay. Do I want to use a direct thrombin inhibitor? Not required, because these patients are not at risk of thromboembolism. So I will not use a direct thrombin inhibitor. I will follow only beta blocker will be used in the mechanism. Of course, if the patient is unstable, I have to again go for the shock treatment only. That is without any doubt. But most of the times, the atrial flutter patient would be stable. So that's why the treatment is only beta blocker. Now quickly look at the ECG which I have put up in the next page. We are now focusing on this area. What are the things you will initially look at? What are the things you will initially look at? Yes, you will look at the QRS. How is the QRS? Again, can you see only two small squares are there? Only two small squares means it's a narrow QRS. And very easily you can say whether it's a regular rhythm or irregular rhythm. Compared to the previous one, you can very easily say that it's a regular rhythm. That's also a point favoring atrial flutter. Anything else is there? Anything else is there? Look at the P wave. Look at the P wave. It is looking like a P wave, but look at the pattern. Okay, the P wave is not having a normal appearance. It is a little irregular appearance. Can you see that? Something like this. Okay, I will use a different color. See here. Like this. Can you see that? Something like this. Can you see that? This is an usual P wave, but one more is also there, which is like a ectopic focus. Can you see that? Usual P wave, one more is like ectopic focus. Usual P wave, one more is like ectopic focus. So what is that? It is looking like this, like this. What is this called as? This appearance is what we call it as. Any comments? This is what we call sawtooth appearance of the P wave. This is very classical. Sawtooth appearance of the P wave. Are you able to understand this? This is a classical thing. Okay. So quickly look at the ECG finding. Atrial fibrillation, you have narrow QRS with irregular rhythm and fibrillatory wave or a F wave. Whereas in atrial flutter, you have a narrow QRS with a regular rhythm. But what is the appearance of the P wave? It's called sawtooth appearance of the P wave. I hope we can follow that. These are the two important examples of tachyarrhythmia. Are you able to follow? Atrial fibrillation is irregular, atrial flutter is regular. So I go back to this classification of narrow complex tachyarrhythmias. I have completed the discussion of atrial fibrillation and atrial flutter. One more thing which is left is the regular one. What is that? PSVT, paroxysmal supraventricular tachycardia. And please remember what I have written on that page. I have written what is that? It's the most common arrhythmia in a childhood. Most common arrhythmia in children. It is PSVT only. Most common arrhythmia in children is PSVT. Okay. And what are the features of this PSVT? First of all, it looks like a regular rhythm or an irregular rhythm. Definitely, it is looking like a regular rhythm. Correct? Definitely looking like a regular rhythm. Second thing, look at the QRS duration. Can you see that? It is only two boxes or two small squares only. So it's again a narrow QRS. I think that is clear. Regular rhythm as well as it's a narrow QRS. Okay, right. Then third thing, is it tachycardia or not? Definitely there is tachycardia. Can you see? Why? Because the waves are very short. If I want to, let's just put it like this. What is that? RR. That is how you calculate the heart rate, right? Between two R's, you calculate the heart rate. Can you see that? Okay, so how many boxes are there? Here I'm seeing 5 boxes. Here 5 boxes are there, and here 3 boxes are there. 5 plus 3 is 8. So between 2 RR, I have 8 small squares. So how will I calculate the heart rate? Heart rate is calculated as 1500 divided by number of small squares. How many small squares I told you? 5 plus 3. That is the number of small squares. So totally 8 small squares. So divided by 8. 1500 divided by 8 is roughly around 187. You can see now it is just less than 200. So it is around 187. So definitely this is a tachyarrhythmia. Are you able to follow? And what is the range of heart rate in case of PSVT? I told you it is typically heart rate of 150 to 250 per minute. That is the range also we are seeing in this particular ECG also. Okay, right? So I'm going to write the ECG features quickly. Number 1 is tachycardia. Definitely it is there. Second, regular rhythm. Along with that, you have a narrow QRS also. Third is you are going to comment on the T wave, correct? T wave. Look at this complex. I'll take the example here. Okay, so this is a QRS complex. This is a T wave. Again, QRS complex, and then the T wave like this. Are you able to make out a definite P wave? I'm writing query P wave. I'm not able to make out a definite P wave. See, it looks again as if the P wave is absent, but here actually the P wave is not absent. The P wave, please remember this, P waves are not visualized because they are merged in the QRS complex. Very important. See, it is possible. Why? Because so much of heart rate, P wave can get merged, okay, in the QRS complex. That is why P wave is appearing as if it is absent. Are you able to follow this? P waves are actually not absent. It is merged in the QRS complex. Are you able to follow? So these are the 3 findings which you should remember for this PSVT, paroxysmal supraventricular tachycardia. Now I'm going to tell you about the mechanism, how this is occurring. See, usually this is a condition which is precipitated by something like a fever or something like a stressful event, for example, competition, something like that. It's a condition which has got some precipitating factor like a fever or a stress. I will tell you what is going to happen. First, let us see what is normally happening. Normally, what is happening? SA node, impulse pass to the AV node, and then to the bundle of His and the Purkinje fiber. That's what you all know about, right? SA node, AV node, then you have the bundle of His and the Purkinje fiber. This is a normal electrical pathway. Now, in case of PSVT, what is going to happen? I'm going to write like this. Normally, there is an impulse SA node to the AV node and then to the Purkinje fibers. Now, what happens is that one of the impulses which is produced from the AV node, will turn like this, and it will again stimulate the AV node to produce one more impulse from the AV node to the bundle of His and the Purkinje fibers. So, what I'm trying to tell you, it is something like a short circuit, inside the heart itself. Where what happens? Normally, the impulse from the atrium should go to the ventricle via the AV node. It is happening. But at the level of AV node, one of the impulse will turn back and again excite the AV node itself. This is something like a short circuit inside the heart. I hope you are able to follow this. Something like a short circuit inside the heart. And this is what we call it as re-entry mechanism. Are you able to follow this? It is something like the impulses go back into the AV node itself. That is, re-enters into the AV node itself and cause one more impulse formation. That is why it is called re-entry mechanism or a short circuit mechanism. That's what we have to remember. That is why this type of arrhythmia is also called as AVNRT. In expansion for this, AV means the AV node, AV nodal re-entry tachycardia. AV node re-entrant tachycardia. Are you able to follow this? Okay, this is what we call AV nodal re-entrant tachycardia. This is the mechanism of this particular PSVT. I hope you're able to follow this. That's one of the impulses turning back and stimulating the AV node to create more impulses. That is what is called AV nodal re-entrant tachycardia. Are you able to understand this, everyone? Okay, so quickly the recap of the mechanism. In atrial fibrillation, there were multiple ectopic foci producing so many impulses. In atrial flutter, there was a single ectopic foci producing many impulses. And in PSVT, there is no ectopic foci. It is something like one of the impulses re-entering into the AV node and causing one more stimulation of the AV node, which is not a normal stimulation. Are you able to understand this? This is what we call AV nodal re-entrant tachyarrhythmia. Okay, right. So now in this patient, how I'm going to treat it? Again, it depends on whether the patient is stable or unstable. For a stable patient, what would I give? Any idea? Any comments on this picture? Any comments on this picture? Just a minute, I'll take out the picture. Okay, comment on this picture. What are we trying to do in this picture? Yes, you can tell me. What are we trying to do in this picture? We are actually stimulating this area of the neck. What is the area of the neck? It is mentioned here. Carotid sinus. Or what we are doing is we are just massaging, gently massaging the carotid sinus area. What is the advantage of massaging the carotid sinus area? In the carotid sinus area, there are something called carotid bodies, which are related to the vagus nerve. Or in other words, what are we trying to do by stimulating the carotid sinus? We are stimulating the vagus nerve. We are stimulating the vagus nerve. This is what we call it as vagal maneuvers. This is what we call vagal maneuvers. Vagal maneuver is nothing but you are increasing the vagal stimulation. And because of vagal stimulation, what is the effect on the heart rate? It will decrease the heart rate. Very simple. It is going to decrease the heart rate. Are you able to understand? It is going to decrease the heart rate. Okay, that is a very simple thing which we are doing. And one of the important examples of vagal maneuver is carotid sinus massage, as I have put up in this picture. Carotid sinus massage. That is number one. Any other vagal stimulant maneuvers you know of? You can keep something like an ice pack, over the eye area, and that ice pack also will cause stimulation of the vagus nerve. So ice pack maneuver can be done, which is kept over the ice. Okay, right? Ice pack over the ice. Anything else? Number three, Valsalva maneuver. That can also be done. Valsalva maneuver can also be done. Okay, Valsalva maneuver also can be done. So carotid sinus massage. Number two, the ice pack can be kept over the ice. And number three would be the Valsalva maneuver. All these are important things which you should make a note of. Is that clear? Are you able to follow? So carotid sinus massage, ice packs in the eye, and one more is the Valsalva maneuver. All these are examples of the vagal maneuvers which can be done for a patient to decrease the heart rate in case of PSVT. This is what we do in the emergency room. Okay, so vagal maneuvers. Right. Clear. So that will be number one. Number two, can you think of any drugs which can slow down the heart rate? Yes. No, atropine will increase the heart rate. This will be decreasing the heart rate. What is that? IV adenosine. What is the adenosine going to do? The adenosine is going to decrease the conduction through the AV node, thereby decreasing the heart rate. That is the point to be noted. Okay, right? Right? It is going to decrease the heart rate. Okay, IV adenosine. Are you able to follow this? Okay, so one is the vagal maneuver. Second one is the drugs which can be used for a stable patient. Okay. What about the unstable patient? Unstable patient means somebody who's having a decreased blood pressure, all those things. Here again, we have to provide shock in the form of synchronized cardioversion. Synchronized cardioversion. It's also called by another name. What is that? DC shock. What does this DC means? Direct cardioversion. That is what it is called as a DC shock or direct cardioversion shock. Are you able to follow this? Okay, this is what you have to remember for a patient who is having a synchronized cardioversion. Okay, is that clear? Able to follow this? Okay, so this will be for a patient who's having this particular condition of PSVT. Okay, now we are moving on to a scenario. You can just tell me, look at this scenario and try to tell me this. Okay, yes, we are having a 2-year-old child who is presenting with fever, tachycardia, and PSVT is noted on the ECG. Okay, right. Hence, IV adenosine was administered to which the child is responding. Of course, PSVT we are going to treat with adenosine only. After stabilization, the repeat ECG shows the following finding, which condition should be suspected. So this is the ECG finding after you have completed the treatment for PSVT. Any comments about this? First one, we'll start with the P wave. This is the P wave, this is the QRS, and this is the P wave. Okay, now comment on the PR interval. How are you going to calculate the PR interval? From the beginning of the P wave to the beginning of the QRS complex. It is only 2 boxes. Is it a normal PR interval? What is the normal PR interval I told you? It should be 3 to 5 small boxes or 5 small squares. Okay, this is only 2 small squares. So number one is very clear. Short PR interval, correct? It's a short PR interval. That is the number one finding you see. Second thing, look at the arrow mark. Is it a normal QRS complex? Is it a normal QRS complex? See, normally it should be like this. P wave, then QRS, and then P wave like this. This is how it is supposed to be. But here what is happening? Here you have a P wave, and then the QRS is like this. Any comments about the duration of QRS? First of all, it is a narrow QRS or a wide QRS. Can you see that? From here it is starting, and here it is ending. How much? It is something like 4 boxes. So definitely it's a wide QRS. It's a wide QRS complex, right? It's almost like 4 boxes it is there. It's a wide QRS complex, number one. Number two, this is the area which I want you to remember. The QRS is beginning at a slow rise. Can you see that? And then only it is quickly picking up. It is not a normal looking QRS. This is what we call it as a slurring of the QRS complex. Slurring of the QRS complex. Any of you know what is the name of this call? This is what we call delta wave. This is called as a delta wave, where there's a slurring of the QRS complex called as the delta wave. So 3 findings I have told you here. What are they? Short PR, wide QRS, and third is a delta wave which is present. Can anybody tell me this? What is the name of this call? What is the name of this? This is what we call WPW syndrome. Okay, any expansion for that? Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. So what is this Wolff-Parkinson-White syndrome? Very simple. It is something like additional pathways which are present inside the heart. Wolff-Parkinson-White syndrome is a condition characterized by accessory pathways inside the heart. Accessory pathways which are present in the heart. Any idea how it is going to appear like? See, again, this is the normal electrical condition. From the SA node, we have the AV node, and from the AV node, we have the bundle of its like this. Normally, this is what it is, right? Normally, this is what it is. Are you able to follow this, right? Now, what happens in the accessory pathway? It would be something like this. From the SA node, directly, there will be connections to the ventricles. There will be connections to the ventricles like this. See, this is the ventricle area. From the SA node, you will have some additional fibers which are connecting directly to the ventricle, which is actually bypassing sort of AV node. Any idea what do you call these accessory pathways, or what do you call these fibers as? This is what we call as bundle of Kent. The name of this fibers is called bundle of Kent. Right. So what is the problem here? What is the problem here? The problem is, even before the impulses from the SA node reach through the AV node and then to the bundle of his, through the bundle of Kent, what will happen? There will be early excitation of the ventricles through this bundle of Kent. Are you able to follow this? That is why this condition is called pre-excitation syndrome. That is why it's called pre-excitation syndrome. Pre-excitation of what? Pre-excitation of ventricles. What is causing the pre-excitation of ventricle? It is the bundle of Kent which is causing the pre-excitation of ventricle. So this is one of the conditions which is called pre-excitation syndromes. It is called pre-excitation syndrome. I hope you are able to follow this. Pre-excitation means something like early excitation of the ventricle or early depolarization of the ventricle. This early depolarization of the ventricle is the reason why you get which wave? You get a delta wave. Are you able to follow this? Delta wave. So I'm going to draw this ECG again. So P wave will be there. And very shortly the QRS will start. Why very shortly the QRS will start? It is due to pre-excitation of the ventricle, right? And that early excitation is not like a normal excitation. So what happened? It will start early, but it will start slowly like this. And then when the normal impulse reaches, there will be a normal QRS complex like this. Right? So can you see what is happening? The distance between the P wave and the QRS is decreased. That is why I call it as a short PR interval. Second thing is here, what is that? The initial part of the QRS is little slurred like this. What is the slurring wave called as? Delta wave. Are you able to understand this? These are the characteristic associations of Wolff-Parkinson-White syndrome, which you should remember. And of course, this is not a normal pathway. Because of this accessory pathway, there will be increased risk of arrhythmias. What is arrhythmia we are talking about? There is an increased risk of PSVT. Are you able to follow? Due to increased excitation of ventricle, there is paroxysmal and supraventricular tachycardia. That's all. So there is an increased risk of PSVT in this condition. That is why, can you see how the question was starting? This child had a PSVT, and after treatment of PSVT, you see the condition of Wolff-Parkinson-White syndrome. That's all. So what I was trying to tell in this particular question is, Wolff-Parkinson-White syndrome is associated with the increased risk of PSVT. That's all. Are you able to follow this? Everyone able to follow this? Okay, right. And Wolff-Parkinson-White syndrome, the features can be remembered like this: WPW. How? It is something like this. What is that? W for wide QRS. Easy. Wide QRS. Then P for PR interval. What is happening to the PR interval? It's a short PR interval. And one more W is for the weird wave. What is the weird wave you're seeing there? I am seeing a delta wave there. That's all. So this is how you can remember the features of Wolff-Parkinson-White syndrome. Clear? Are you able to follow this? Okay, this is how we can remember the features of Wolff-Parkinson-White syndrome. Clear? So any drug which can decrease the conduction through this pathway, drug which can be used for this purpose? Any idea? What's the usual treatment we give to decrease the conduction through this pathway? See, these are all pharmacology questions which you should be able to answer. Procainamide, that is the drug of choice. Procainamide. So many drugs are used, but the drug of choice is procainamide. Don't forget, that would be the drug to decrease the conduction through this accessory pathway. Any other thing? What would be the definitive treatment? Any comments, anybody? What would be the definitive treatment? What would be the definitive treatment? You have to destroy this pathway. How can you do the destruction of the pathway? It is by radio ablation. Radio ablation of that particular pathway. Simple. When the patient is presenting for the first time with Wolff Parkinson-White syndrome related problem, I will give a drug to control the pathway activity with the help of procainamide. If the patient is presenting multiple episodes of arrhythmia, then I will go for the definitive treatment, which will be radio ablation of the particular pathway. That's all. This is the condition of WPW syndrome, Wolff Parkinson-White syndrome, one of the important conditions associated with arrhythmias. Is that clear? So with that, I have completed the discussion of the three important arrhythmias. What are they? Atrial flutter, atrial fibrillation, as well as PSVT. If I want to make a quick distinction between the three conditions, you don't need to write this separately, just for a revision purpose. All the three arrhythmias which we have discussed have a narrow QRS. Narrow QRS, correct? And how do you divide these arrhythmias into regular rhythm and one more is irregular rhythm? You don't need to write this, just listen. Regular rhythm, what are the two things? What are the two things? PSVT and one more was atrial flutter, correct? Irregular rhythm, what is the example? Only example, AF, atrial fibrillation. If you think of the pathology, atrial fibrillation had multiple ectopic foci. Atrial flutter had a single ectopic foci. PSVT had a re-entry mechanism, correct? Re-entry through which node? AV node re-entry mechanism. That is what it is. Okay, right? Okay. Now, what is the heart rate looking like? In PSVT, it was something like 150 to 250 per minute, slight increase in the heart rate. Atrial flutter was more than that, 250 to 400 per minute. Atrial fibrillation, it was 400 to 600 per minute. And atrial fibrillation, because of multiple ectopic foci, there is also a problem of what? Clot formation. There is a problem of clot formation. That is why in the management, you have to provide what? Direct thrombin inhibitors. However, in these two conditions, there is no clot formation, correct? There is no clot formation. So there is no need for any anticoagulation. Then I told you what are the drugs which we are using for the control of the heart rate in this patient. Atrial fibrillation and atrial flutter. I told you it is going to be atrial flutter and atrial fibrillation. What is the drug I told you? It is going to be beta blockers to decrease the heart rate, I told you. This would be for a stable patient. For PSVT, what is the drug I told you? It was adenosine, drug to control the heart rate. In PSVT, I told you. That is also for a stable patient. In case the patient is unstable in any of this condition, what will be the treatment? It is synchronized cardioversion or DC shock. What is that? Direct cardioversion shock is recommended. I think these are the things which I have told you as a summary of narrow QRS tachycardia or what we call supraventricular tachycardia. I hope till this point it is clear. Everyone able to follow this? Okay, this is a summary of whatever I have discussed in the section of narrow QRS tachycardia. Clear? Okay, right. Then I am moving on to the discussion of wide QRS. What is the wide QRS? The wide QRS is ventricular tachyarrhythmia. Wide QRS is ventricular tachyarrhythmia. And two names I have told you. What are they? Ventricular fibrillation and ventricular tachycardia. What would be regular rhythm? VT, ventricular tachycardia, is the regular rhythm. Irregular is ventricular fibrillation. VF, ventricular fibrillation. I think you can easily remember. I told you. Atrial fibrillation is a regular rhythm. Similarly, ventricular fibrillation also will be a regular rhythm. Ventricular tachycardia will be like a regular rhythm. Are you able to follow? And please remember what is the definition of wide QRS? It would be more than 3 small squares will be the QRS complex. That's the point to be noted. More than 3 small squares. I hope you are able to follow this. More than 3 small squares. Clear, everyone? Okay. We will start a discussion of ventricular tachycardia, which is a regular form of ventricular tachyarrhythmia. There are two names, as you can see. One is monomorphic, another one is called polymorphic. Morphic means what? Basic question. What is the meaning of morphic? Morphic refers to the shape. If the shape is like this, what is that? Can you see that? It is like a regular shape. I will call it monomorphic VT. And if it's something like this, what is that? Can you see that? It's a irregular shape. That is called polymorphic VT. That's all. Very simple. Everywhere the shape is same, it is monomorphic, and everywhere it is different, it is called polymorphic VT. I hope you are able to follow this. Clear? This is called polymorphic VT. I am going to start the discussion of monomorphic VT. Okay, monomorphic VT. You can write on the next page. Monomorphic ventricular tachycardia. That would be the first discussion. See, monomorphic ventricular tachycardia is the shape will be like this one. However, it can occur in a patient who is stable or who is unstable. Patient who is stable or who is unstable. See, there's nothing much to discuss about BT because the shape will be like this one, right? If you want, I put up the picture also. See, this is how it will appear. Can you see this picture? The first one. Can you see this? This is actually the monomorphic BT. Can you see that? Everything is like this. Wide QRS, as well as it is regular. That's all. Are you able to follow the regular rhythm as well as wide QRS? That is what is ventricular tachycardia. I hope you're able to follow this. Now the question is, if it is a stable patient who's having monomorphic VT, what is the drug to control? It is procainamide. Very important. It is procainamide, which will be the drug of choice. It would be the procainamide. Okay, that would be the drug to control monomorphic VT. Now, unstable patients, usually any area where it is encountered, unstable patients who are having ventricular tachycardia, it is usually in the situation of cardiac arrest situation. I'm going to discuss about that shortly. Cardiac arrest situation. In cardiac arrest situation, again, what you have to provide? You have to provide a shock. But remember, during a situation of cardiac arrest and all, we cannot synchronize with the R wave. I told you, for atrial fibrillation, atrial flutter and all, you have to provide a synchronized cardioversion that we synchronize with the R wave. But in case of a cardiac arrest patient, we cannot synchronize it up. So what is given is unsynchronized shock. Unsynchronized shock. And this is what we call it as defibrillation. This is what is called defibrillation. Okay. Please do remember, ventricular tachycardia is unstable. You have to provide, ventricular tachycardia is unstable. You have to provide defibrillation. Also remember, in cardiac arrest situation also, you can get ventricular fibrillation. VF also can be noted in case of cardiac arrest. There also, what is the treatment? It is going to be unsynchronized shock. Okay, please make a note of this. So, this is what. Can you see the ventricular fibrillation here? Ventricular fibrillation. This is also wide QRS only. This is also wide QRS. But do you see very clearly? It is an irregular one. It is irregular. Can you notice that? It's very irregular. Compared to the previous one, you can see the rhythm is irregular. So, wide QRS, irregular rhythm, it is ventricular fibrillation. Please make a note of this. These two can be noted in cardiac arrest situation. These two can be noted in cardiac arrest situation. And whenever it is noted in cardiac arrest situation, the treatment is going to be shock. What type of shock? Unsynchronized shock or defibrillation is the treatment. VT alone, ventricular tachycardia alone, can be noted in a stable patient also. And for a stable patient, I told you, what should be the treatment? It would be procainamide. Are you able to follow this? Okay, right? So just revising again, VT and VF can occur in a cardiac arrest setting. In that setting, it is only shock treatment. VT alone can occur in a patient who is stable also. And for a stable patient, for the rhythm control management, you have to give procainamide. That is the point which I want you to remember. I hope till this point it is clear. Okay. Now there is only one more thing which needs further discussion. What is that? Polymorphic VT or polymorphic ventricular tachycardia. Polymorphic means what? See, it is a regular rhythm only. Don't forget, it's a regular rhythm, but the shape will be variable. Can you see that? The shape of the QRS is variable. The rhythm is regular only, but the shape is variable. That is what we call polymorphic VT. Any of you know what is the name of this condition? What do you name of this condition? It is something like this. It is something like in the party and all. Okay, it is something like in the party where we have that bloopers and all. No bloopers, like we twist that particular. That particular party bloopers or what we call party steamers. Can you see that? Something like that, a paper only, which is twisted like this, right? So it's something like one point you twist it, other areas will get twisted like this. So this is looking like what? This is looking like a party steamer. Okay, party steamer or something like a party blooper like that. What do you call this? It's something like twisting around the point. Can you see that? Twisting around the point. And that is what we call it as Torsades de Pointes. This is what we call Torsades de Pointes. Simply called as twisting around the point. This is a description of what type of ventricular tachycardia. Polymorphic VT is what we call in the ECG as Torsades de Pointes. Okay, Torsades de Pointes, twisting around the point. Able to follow this, right? Okay, an important MCQ question for the exam is, what are the associations of polymorphic VT, which you can write from the next page. Okay, polymorphic VT, what are the associations, or what are the risk factors for polymorphic VT to occur? There are so many risk factors actually, and for you to remember in your exams, you can take a mnemonic as the name itself. What is it? Torsades B, pointers. Pointers will be the mnemonic for you to remember. Pointers. Any of you know? I am sure in some of your pharmacology classes also you have cleared about this. Can anybody tell me P for what? P for some drug actually. Which drug? Phenothiazines. 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 Okay, right? O for others. Other group of antipsychotic medication. Example like TCAs, tricyclic antidepressant. They can also be associated with polymorphic ET. I for intracranial bleeds. Intracranial bleeds. N for no known cause. No known cause, meaning it's an idiopathic condition. It's an idiopathic condition. N for no known cause. One more T. Some types of anticoagulants. Some type of anticoagulants. So not anticoagulant, I'm sorry for that. Antiarrhythmics. Some type of antiarrhythmics. Any of you know which antiarrhythmics predisposed to this condition? Any of you know which antiarrhythmics predisposed? See, there are many groups of antiarrhythmic which I'm sure you must have heard about. Okay, there are many groups of antiarrhythmic you might have heard about. Type 1, type 2, type 3, and one itself we have 1A, 1B, 1C, and all. The common ones which are associated are 1A, 1C, as well as 3 also. Okay, right? I'm not going to individually write the names, but these are common groups. 1A, 1C, as well as 3. This is what you have to remember. Okay, these are the important association for type of antiarrhythmics, and I am sure that it must have been sent in your pharmacology classes also. One of the important questions for your exams. Okay, what arrhythmias, what antiarrhythmics are associated with polymorphic VT? Second important question is for E. Any idea what is the E refer to? Electrolyte imbalances noted in this condition. Any of you know what are the electrolyte imbalance noted in this condition? Any of you know that? Hypokalemia, hypocalcemia. One more, hypomagnesemia. These are the important association. All hypos actually, hypokalemia, not hyponatremia, but other three things: hypokalemia, hypocalcemia, as well as hypomagnesemia. So 3 important things. Okay, please make a note of it: hypokalemia, hypocalcemia, and hypomagnesemia. That is why in the treatment of polymorphic VT, you know what is the drug which we give for treatment? I'm writing like this: treatment. Any of you know what is the treatment? Intravenously administered magnesium sulfate is the usual treatment we give for polymorphic VT. Are you able to follow? Polymorphic VT. Other drug which can be useful only is the lignocaine. Lignocaine also can be useful. However, the initial drug, or if you want to choose one option for polymorphic VT, please choose the answer as IV magnesium sulfate, intravenous magnesium sulfate. Please don't forget this. Okay. Last one is the S. S for some syndromes. This is definitely not your exam question. Just for completion, I'm telling you one syndrome alone. I will tell you something called Romanov-Ward syndrome. Romanov-Ward syndrome. Okay, don't go into the details. I'm just writing only for completion purpose. Only for completion purpose, I'm writing it. It's actually not needed for your exams. It is for completion. I'm writing it. Okay, polymorphic VT. These are all the association. The treatment for polymorphic VT is magnesium sulfate administration. And if it is not responding to that, you can go for lignocaine. But the usual drug of choice will be only magnesium sulfate. Clear? Hypoglycemia, no. It is not hypoglycemia. On the other electrolyte abnormalities. Okay, fine. Is it clear, everybody? Able to follow this? Okay, so that's about the discussion of ventricular tachyarrhythmias. Okay. And whenever I'm going to discuss about ECG, it is not complete without discussing the heart rhythms which you can encounter during cardiopulmonary resuscitation. So think like this. I am writing like this: during cardiopulmonary resuscitation of the child. The same can be for an adult also. Adult also is the same only. During cardiopulmonary resuscitation of a child, the following ECG is obtained. What should be the next step? What should be the next step in the management? That is what is the question. What should be the next step in the management? Any comments? See, first of all, let me just put up the steps in CPR, basic steps in CPR, and then I will come back to this question. Okay, basic steps in CPR. What we are following now is something called 2020 guidelines. I think all of you know, American Heart Association has updated the guidelines in the year 2020, last update, and that is what we are following also. Okay, right? Any of you know about the basic steps in CPR? First thing, whenever a patient is suddenly collapsed, that is when you have to start the CPR algorithm. Sudden collapse. Maybe you are in a ward, or maybe you are in a public place, or maybe you are in an ICU. A patient has suddenly collapsed. What is the first thing you will go and check in that patient? Of course, we will try to assess the responsiveness. Of course, you have to assess the responsiveness, whether he's responding or not. And of course, if you're alone, you have to shout for help. You have to shout for help also. Right? This is okay. This is a quick thing. But what are you going to check in that patient? You are going to check two things simultaneously. What are the two things you're going to check? You're going to check the pulse as well as you're going to check the breathing. Any of you know within how many seconds you should have made the decision whether the patient is having a pulse and breathing? It should be done within 10 seconds. It should be done within 10 seconds. Within 10 seconds, you should make a decision whether the patient is having a pulse and a breathing or not. And what is the usual situation? I will discuss only that. No pulse, no breathing. No pulse as well as breathing. No pulse or breathing. That is the usual situation, right? Pulse and breathing is absent. So when the pulse and breathing is absent, what will you do? You are going to immediately start CPR. You are going to start CPR. That is chest compression. You are going to give chest compression. Not only chest compression, you can give chest compression along with, see, whenever there is no breathing, you have to support breathing also, ventilation also. Like for example, with the bag and mask ventilation, that is what you're going to do. Chest compression along with ventilation. For example, the patient is breathing, but there is no pulse. You can only do a chest compression. That is also okay. But what I am talking is about the usual situation where there is no pulse as well as no breathing. So compression should be combined with ventilation, like bag and mask ventilation. Any of you know what is the ratio in which we give this compression and ventilation? Any ratio? It is 30 is to 2. That is what you have to remember. This is the ratio which we follow for an adult. 30 is to 2 ratio. Don't forget this. This is the ratio which we follow for an adult. Right? So 30 is to 2. 30 compressions and 2 ventilations, like a ratio we have to maintain. This is what we need to remember. And we have to keep doing this CPR. And at one point of time, whenever AED is available, you have to connect the AED. What is that? Automated electrical defibrillator. I hope all of you know this. AED, automated electrical defibrillator. Electrical defibrillator. AED, correct? Automated electrical defibrillator. All right. Okay. So this is how the AED. I think all of you must have seen the AEDs. It is available in the common places also. Even in the public places also, this AED is available. 1 minute. Let me just see whether I have the picture here. Okay. I think it is not here, but it is something like this. What is that? It is something like 2 pads. One over the sternum area you connect. Another over the left side of the chest you connect. That is what it is. Okay. If you want, I'll just put up that image also. Just give me a minute. I'll just put up that image. Just a minute. Okay. I think you can see that here. This is the AED. This is the automated electrical defibrillator. You can notice that it is something like 2 pads, okay, which are actually applied. Okay, it is actually the 2 pads which are applied. Can you see that one on the chest area, other one, both on the chest only, one over the sternum area, slightly to the right side, and then one on the left side of the chest. Can you see that? This is the AED, okay, right? So what you have to do is, once you apply the AED, what is the advantage of applying this AED during the time of CPR? Very simple question. It will analyze the rhythm, okay? It will analyze the rhythm. I'm going to write here. Once you connect the AED, that AED will analyze the rhythm. Okay, it will analyze the rhythm. And based on the rhythm, that is the electrical activity in the heart, we will get it like an ECG tracing only. There are 2 types of rhythm. You can continue from the next page also. There are 2 types of rhythm. What are the 2 types of rhythm? One is called as a, yes, shockable rhythm. Shockable rhythm. Another one is non-shockable rhythm. Right? Non-shockable rhythm. What are the two shockable rhythms? I have already told you during the time of cardiac arrest. I told you VT. What is that? Ventricular tachycardia. One more is VF. See, in your exam, in your books and all, you will see like this is written. What is the PVT? What is the meaning of PVT? It is nothing but pulseless VT. Just to tell you, it's a cardiac arrest situation. That's all. PVT or ventricular fibrillation. What should be done? Without any doubt, you have to administer the shock. This is what is a shockable rhythm. Any idea what is the non-shockable rhythms? Any of you know what is the non-shockable rhythms? There are two rhythms actually. One is a flat line. What is a flat line? What is this flat line? Asystole. One more is something like you see an electrical activity like this, but there is no pulse or the heart rate is zero in that patient. What is this? What is this? It's a no pulse, but there is some electrical activity. You call this as PEA. What is that? Pulseless electrical activity. Okay, this is called pulseless electrical activity. Both these are non-shockable rhythms. Okay, both these are non-shockable rhythms. For non-shockable rhythm, you should remove that device because that is not going to be useful because anyway shock cannot be administered. So the previous teaching for the non-shockable rhythm was what? You have to continue CPR. That is what. Because anyway shock is not going to help in this case. That's why it's for non-shockable rhythm. You have to continue CPR. But do you know what is the update which has come? The update is saying very clearly now that for all non-shockable rhythm, you have to administer epinephrine. You have to administer adrenaline or epinephrine ASAP. As early as possible, this epinephrine has to be administered. Then only you have to continue CPR. You know what was the previous teaching? The previous teaching was, if it is a non-shockable rhythm, you continue CPR and last only you give adrenaline or epinephrine. But now what they are saying, if it is a non-shockable rhythm, as early as possible you give adrenaline and then you continue CPR. Because so many studies have proven that in a non-shockable rhythm, early administration of adrenaline or epinephrine is found to have a better outcome. That is why it is now first you give epinephrine and then you continue CPR for a non-shockable rhythm. I hope it is clear till this point of time. I hope it is clear till this point of time. So very simple. Just a quick revision of whatever in the CPR I have told you. First thing you have to do is you check the pulse and the breathing. Usually in a situation of collapse, pulse and breathing will be absent. You have to start CPR. No pulse and breathing, you have to start CPR. You give CPR in a ratio of 30:2. Don't forget this is an important ratio for you to remember. And you have to connect AED whenever that AED is available. Okay, automated electrical defibrillator. What is the AED going to do? It is going to analyze the rhythm and divide it into shockable and non-shockable rhythm. If it is a shockable rhythm like VF or VT, you administer shock. That is the point you need to remember. If it is a non-shockable rhythm, what is the update? You have to give epinephrine and then only you have to continue CPR. So first will be adrenaline or epinephrine. Second only would be the CPR continuation. This is for a non-shockable rhythm. And don't forget, this is an important update topic. Clear? Now I will take you back to that question and now you answer this. You are doing a cardiac pulmonary resuscitation of a child and the following ECG is obtained. What will be your next step? What is the ECG first of all? It looks as if there is an electrical activity inside the heart. That is true. But don't forget what is written. The heart rate is 0. What does it mean? Patient is in cardiac arrest. There is no pulse, but there is some electrical activity noted. So what do we call this? This is what we call PEA. So this is a situation of pulseless electrical activity. What is this? It's a non-shockable rhythm. So what will be your next step? Just now I told you for all non-shockable rhythm, you have to give adrenaline or epinephrine and then only you have to continue CPR. Okay, previous teaching was assume chest compression only, but now it is adrenaline administration and then only you have to give chest compression. Are you able to understand this? So this is about the discussion of CPR in children. Sorry, not only in children, even in adults also it is the same thing. That's what I want you to remember. Okay, clear? Okay, just one question I wanted you to tell me. I told you compression ventilation ratio. For an adult, it is 30:2. Can anybody comment on a child? For a child, you are doing CPR. What should be the ratio? It can be either 30:2 or it can be 15:2. Any comments? 30:2, if only 1% single rescuer is available, the ratio will be 30:2. If there are 2 rescuers available, how will be the ratio? 15:2. That is the point to be noted. Third question, for a neonate, what do you think is the ratio? For a neonate, the ratio is 3:1. For a neonate, the ratio is 3:1. Don't forget, for a neonate, it is 3:1. Very good. Neonate, it is 3:1. So remember, adult, it is fixed at 30:2. Neonate also, it is fixed at 3:1. But for a child, depending on the number of persons available for resuscitation, it can be variable, 30:2 or 15:2. Are you able to follow this, everyone? Right. Okay. So that's about this particular section of cardiac arrest and some ECG patterns. Finally, coming on to the last ECG pattern, which you have to know for your exam, it is something related to electrolyte imbalances. Something related to electrolyte imbalances. Any comments? Something related to electrolyte imbalances. Okay. One will be related to the hyperkalemia. Okay. See, basically two things I'm going to tell you: hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia. These are the things I'm going to tell you. What is the normal level of potassium? Normal potassium levels, it is something like 3.5 to 5.5 milliequivalents per liter. Okay. Hyperkalemia will be more than 5.5 milliequivalents per liter. Simple. And can anybody tell me what is the role of potassium in the ECG? It is not ECG I'm talking about. I'm talking about what is the role of potassium in the electrical activity of the heart. What is the role of potassium? Is it related to the atrium or ventricle? It is more related to ventricles. Is it ventricular depolarization or repolarization? Potassium is related to ventricular repolarization. Or I'm going to write the levels of potassium are directly proportional or directly correlated with the level of ventricular repolarization. Don't forget, ventricular repolarization. That's what you have to remember. Potassium is related to ventricular repolarization. So more the potassium, more will be the ventricular repolarization. And tell me which wave is reflective of ventricular repolarization in the ECG? Very simple, it is T wave. So more potassium means more ventricular repolarization or more will be the size of the T wave. That is why the characteristic initial finding in hyperkalemia, what is that? It is something like this. The T wave will be like this. Any comment? It's a tall T wave. Not only tall, it is also pointed T waves. Very, very important. Tall pointed T waves. It is the number one change of hyperkalemia, which you should remember. What is the corresponding potassium level? 5.5 to 6.5. Don't forget this. This is the first change. This is the first change. It's an important MCQ question. What is the first ECG finding of hyperkalemia? It is tall pointed T waves. Okay, so don't forget this. What is the second set of changes? That will be for the next potassium level of 6.5 to 8. Any of you know what is the potassium? What are the changes which is going to occur next? These are all like theoretical for you. First thing only is the MCQ question. Even for an ECG question also, they will put up this tall T wave and then ask you about the hyperkalemia part. Other things are all more theoretical only. I'm just quickly going to tell you what is the next set of changes which will occur. It will be like a pattern. There will be increase in the PR interval, increase in the PR interval, which will be progressive. Following that, what happens? There will be an absent P wave. When the potassium increases more, there will be absent P wave. And finally, what will happen? There will be widening of the QRS complex also. Widening of the QRS complex. So increase in the PR interval will occur, absent P wave will occur, and then finally will be the widening of the QRS complex. This will occur one after another as the potassium keeps on increasing. And finally, what happens? You will see only QRS because anyway P wave is going to be absent. Okay, only QRS you will see, and that QRS will be wide, but it would be something like this pattern. Anybody comment on this pattern? What is this pattern? This pattern is called as the sine wave pattern. That would be noted when the level is more than 8. When the level is more than 8. That's what you have to remember. That will be the pattern is noted when the level is more than 8. This is the sequence of event which can occur in the setting of hyperkalemia. Able to follow this? Is that clear, everyone? Able to follow this? Okay, just give me a minute. You copy down this finding. Just a minute. Which are noted in hyperkalemia. Don't forget the first change. The first change is always tall pointed T waves. Okay. Any of you know any other condition where you have a tall pointed T wave? Any of you know any other condition where you also have a tall pointed T waves? Any comment? Okay. One more important condition is myocardial infarction. MI. Myocardial infarction also, one of the first changes would be tall T waves only. But you won't get a tall pointed T wave. Instead, the T wave will appear like this. What is this? This is tall T wave only, but it's a wide T wave. Tall and wide T wave. is a feature noted in myocardial infarction. So you have to differentiate. In both the condition, you have tall T wave, but in hyperkalemia, it's a tall pointed T wave, whereas in myocardial infarction, it's a tall wide T wave. That is a point of difference. Okay, here it is pointed, here it is wide. Is that clear? So that's about the hyperkalemia changes which you should know. Okay, right. Then hypokalemia, of course, levels of potassium less than 3.5 milliequivalents per liter is what we call hypokalemia. And obviously, when there is low potassium, there will be slow repolarization. Very simple, because potassium level is related to repolarization. So it will result in slow ventricular repolarization. Ventricular repolarization. So how is that reflected in the ECG? Can you see the number one? What is that? Slow repolarization is, see, repolarization is reflected in which way? T wave. Because of slow repolarization, what is happening? The T wave is actually like this. What is that? Inversion of the T wave will occur. Number one is inversion of the T wave. Correct? Inversion of the T wave. Inversion of the T wave. Number one. Number two, you can see the segment. What is that? ST segment. This is the ST segment. That is also showing a depression. ST depression. ST depression. And because of the slow repolarization, can you see the slow repolarization is reflected like this wave? After the T, you are having the actual repolarization wave like this. That is indicator of slow repolarization. What is the name of that wave? Additional wave called U wave. So U wave is actually the reflection of the slow repolarization, where the third finding is going to be prominent U waves. Prominent U waves. That's what you have to remember. These are the three findings of hypokalemia, which you should remember. So basically, everything is correlated with the slow repolarization of the T waves. Clear? Are you able to follow this? Okay, right. So that will be for hypo and hyperkalemia as well. Okay, next we move on to the, see, suppose the patient is having a death due to hypokalemia. Do you know what is the cause of death? If it is very, very low potassium levels, it can cause death. And in hypokalemia, see, we are talking about hypokalemia only. In hypokalemia, if at all the patient dies, what is the cause of death? It was one of your previous questions, that's why included. It is respiratory muscle paralysis. Respiratory paralysis will be the cause of death if at all the patient has death with hypokalemia. Okay, right? It is respiratory paralysis, one of your previous year questions. Okay, right. Just make a quick note of it. That is enough. Okay. Clear, everyone? Okay. Just a minute. Okay, fine. I think that is okay. Right now, next one is hypocalcemia. Okay, any of you know what is the normal calcium level? Normal calcium level, see, it is variable, but I'll give you a rough number. 8.5 to 10.5 milligrams per deciliter. That is a normal calcium level that you should know. Okay, 8.5 to 10.5 milligrams per deciliter. Less than that is called hypo, and more than 10.5 is called hyper. That is what you have to remember. And calcium is more related to the depolarization of the ventricle. So that is why in hypocalcemia, what you will get is prolonged QR complex, or what we call QT interval, prolonged QT interval. What is the normal QT interval? I told you it is around 0.4 seconds. I told you it's actually like 0.4 to 0.45 like that. Here it will be prolonged. And in hypercalcemia, it is opposite. What is that? Short QT interval. That's all. These are the only two things which you should remember as far as the calcium levels and the ECG changes are concerned. That's all. Don't go into the detail. Just remember this thing. That is enough. Okay. Prolonged QT for hypo, short QT for hyper. That's what you have to remember. Clear? Okay. So these are all the important ECG findings which I want you to remember for your exam purposes. Okay, right? Definitely, if they want to ask you a picture-based question, some of the important questions are possible in the form of atrial fibrillation, atrial flutter, PSVT, ventricular tachycardia, ventricular fibrillation. Remember, ventricular tachycardia and fibrillation, usually they are going to ask you in the setting of cardiac arrest only. Don't forget that. Don't forget that. That is important. And other things could be hyperkalemia changes, and that too, they will mainly focus on the first change. What is the first change? Tall pointed T waves and hyperkalemia. Of course, one more important set of ECG findings, which I have not yet discussed, which I will be doing the discussion in the section of myocardial infarction, MI, myocardial infarction. That is also important for exam, but we will be discussing along with the topic of coronary artery disease later on. That's what. Okay, right. So now we will move on to the next set of disorders, which will be about infective endocarditis, one topic which we will discuss now, and then we will have the lunch break after that. Okay, right? So, infective endocarditis, something related to the infections. Endocardium means the lining of the heart. Okay. Okay. So, this is more like a theoretical topic at this time, but very well possible clinical scenarios also can be asked in an exam. But you should know so many one-liner questions have been asked in the section of infective endocarditis. And as some of you were saying in my last session itself, some things have been already discussed in your pathology classes. So with that knowledge also, you can try to answer this. So this is basically infection. Okay, so everywhere it's an infection. definitely questions will be related to what organism. Before going to the organism, we will talk about the area which is affected. See, endocardium means something which is lining the heart chamber, like right atrium, right ventricle, all these things. That is okay. But endocardium also refers to lining of these structures. What are these structures which I'm drawing now? Septum as well as the heart valves also. Don't forget this. In fact, in infective endocarditis, the most common area affected is the heart valve only. Any of you know which is the commonest valve which is affected? Which is the commonest valve which is affected in infective endocarditis? It is the mitral valve. Most commonly, it affects the mitral valve. That is on the left side, left atrium and left ventricle. In between, you have the mitral valve, which is the most common site which is affected in case of infective endocarditis. Please don't forget this. And whenever the bacteria is colonizing the valves, it forms small structures on the valves. Any idea what you call these structures? Any of you know what is the name of these structures? I'm sure in your pathology classes they must have told you. What is this? Yes, this is what we call vegetations. This is what is called vegetation. Okay, this is what as vegetation. Okay, basically vegetation is something like looking like this. What is that? In the center, you will have the bacteria like this. In the center, you will have a bacteria. I'm just putting a, I'm just enlarging the vegetation and showing what will be the components of that vegetation. It would be something like a bacteria like this in the center. I'm drawing like this. This is a bacteria. And surrounding the bacteria, what is going to surround the bacteria? What is going to try to destroy the bacteria? It is the macrophages. Something like this. These are the macrophages. And as a part of inflammatory reaction, what will be surrounding this? It is something like a covering here. What is that covering? The covering is nothing but made up of platelets as well as the fibrin mesh. Something like a clot, okay, fibrin mesh. This is actually the microscopic appearance of a vegetation. It is not only bacteria, it is also the macrophages. Sometimes you can get RBCs also. Okay, macrophages basically bacteria, macrophages along with the platelet and fibrin. It's what we call the pathological or microscopic appearance of a vegetation, which is the hallmark finding in the pathology of infective endocarditis. Okay, right. Okay, so as usual, this is an infection. So it goes without saying, you should know about the name of this organism associated with infective endocarditis. Any idea which is the overall most common organism in infective endocarditis? Any comments? Anybody? See, I'm putting a lot of stars here. So many questions have been asked from this particular section. Overall most common is Staphylococcus aureus. Staph aureus. Overall most common. It is Staphylococcus aureus. Okay. However, if they ask you specifically in childhood, what is the most common? It is slightly different. Any of you know? It is something related to the mouth flora and what is that? Streptococcus viridans. Streptococcus viridans. That is for childhood endocarditis. But overall most common as well as in adults, it is Staphylococcus aureus only. Okay? Fine. Now, Staphylococcus aureus, I am going to tell you a few more points also. Staphylococcus aureus is something which can affect a native valve also. Native means a healthy valve, previously healthy valve. Okay, right? Something which can affect a native valve. That means the patient is not having any other problem. Just like that Staph aureus comes and damages the valve. That is what we call native valve endocarditis, something caused by Staphylococcus aureus. Whereas Streptococcus viridans is something which will affect the previously damaged valves. Previously damaged valves. For example, patient had a rheumatic heart disease, and because of that, patient developed mitral stenosis, something like that. You think like this. That is called as a previously damaged valve. That is commonly affected by Streptococcus viridans. So now tell me one simple question. Out of these two varieties, which is a severe variety, or which is the organism causing a severe type of endocarditis? Is it Staph aureus or Streptococcus viridans? Obviously, it is Staphylococcus aureus, which is the severe type. Because you can see, it is something which can even affect a previously normal valve also. So it has to be a very strong or virulent organism to damage a previously normal valve. Whereas Streptococcus viridans is affecting a previously damaged valve. So it's not so much of a severe condition. That's what I'm trying to tell you. Okay, right? And remember, Staphylococcus aureus causes infection not only in a severe way, it also causes infection in a very short time. That is why it's also called acute endocarditis. It's also called acute endocarditis. Whereas Streptococcus viridans causes damage over a long period of time. So it's called subacute endocarditis. Something like many weeks it can take. Subacute endocarditis. This is what in your pathology classes they denoted by a very famous short form. What is that? SAB. SABE. What is that? Subacute bacterial endocarditis, which is a description for Streptococcus viridans associated endocarditis. Are you able to follow this? Right? So please make a note of this. Okay, right. Yes. So native valve and the previously damaged valve, the organisms are different, but overall most common always is Staphylococcus aureus. Then what is the third category? Something which is a prosthetic valve or an artificial valve. Something like this. For example, patient had a mitral stenosis. It was a very severe mitral stenosis. So the patient underwent surgery. Where actually the valve was replaced. Something like valve repair or valve replacement surgery, where new valve is being inserted. That is an artificial valve or a prosthetic valve. Any idea in artificial valve endocarditis, which is the most common organism? Artificial valve endocarditis, which is the most common organism? I will tell you, overall most common is cons. What is cons? Coagulase negative staphylococcus. Any example of that? Staphylococcus epidermidis. That is the overall most common. But your questions can be in two other ways also. What are the two other ways? They can ask you like this: early onset endocarditis and late onset endocarditis. Early onset is something which is within 12 months. Suppose the valve surgery is done today and within 12 months there is an endocarditis occurring, then it is called early onset endocarditis. Obviously, after 12 months is called late onset endocarditis. And if you know what is that for early onset endocarditis, again it is cons, coagulase negative staphylococcus only. Whereas if it is late onset endocarditis following a valve surgery, then it is Streptococcus viridans. Don't forget this. So depending on the question, you have to answer. Okay, that is the point which I wanted you to remember. Depending on the question, you have to answer. Very simple, plain question. Something like, what is the overall commonest cause of prosthetic valve endocarditis? Your answer will be staph epidermidis. That's all. It's over. They are specifically mentioning within 12 months, after 12 months, then you have to answer accordingly. Within 12 months, it is cons, and after 12 months, it is Streptococcus viridans. Last one, in an IV drug abuser. Any comments? Anybody wants to comment on this? IV drug abuser. In an IV drug abuser, the commonest cause is Staphylococcus aureus. Staphylococcus aureus. That's the point. Staph aureus. Right? Staphylococcus aureus for, IV drug abusers. And whenever you use IV, intravenous, which side of the heart is the infection going to come into? Whenever you give intravenous, suppose in this area you are giving, and there is an infection which is going through this area, through the veins, it is going to enter into which side of the heart? Right side of the heart. So here you have right-sided valve lesions. For IV drug abuser, you have a right-sided valve lesion. Like the tricuspid valve or the pulmonary valves are going to be affected. Whereas in all the other situations, which is the overall common type, left-sided valve lesion, like mitral and aortic only. But for IV drug abusers alone, it's a right-sided valve lesion. And this is an important MCQ question. This is an important MCQ question. IV drug abusers, it is right-sided valve lesions. Is that clear? I hope you're able to follow till this point of time. Right-sided valve lesions. Okay, right. And clinically, we can divide the endocarditis into two groups actually. One is called acute, another one is subacute. I have already told you. Acute is something related to Staph aureus, where the features will be like few days only, less than 1 week will be the duration. Whereas subacute is more than 1 week and is more closely related to what? Most commonly related to Streptococcus viridans only. I have told you in the subacute category. But there are other groups also, like Staph epidermidis, Staphylococcus epidermidis, also causes subacute endocarditis only, epidermidis. One more important group, which is actually, okay, I will come to that. One more important group is a enterococci, which is also a part of Streptococcus only. Enterococci. That's what all these cause subacute. And one more is something called a slow-growing organism endocarditis. Slow-growing means actually they take a very, very long time, even up to 1 month also for the infection to occur. And this group of organism is remembered by a name called the Hassek group. You can see that now I've given the expansion of the Hassek group, which is not a single organism, multiple organisms involved, like Haemophilus species, okay, Aggregatobacteria acinitomycins, Cardiobacterium hominis, Echinella corrodens, and Ingella kingae. All these are the Hassek group of organisms. The main thing is they are slow-growing organisms. Okay, even if you subject the culture of this organism, it will take many weeks for the organism to grow. That's why they call slow-growing organism. Obviously, they cause a very, very slow type of disease only. Okay, right? So just for your exam purpose, you should know the names. That's all. That's what I want you to remember. I hope this part is very clear as to what are the different organisms associated with infective endocarditis. At least 4 or 5 questions can be picked up from this section of infective endocarditis. Overall, most common is Staphylococcus aureus. Overall, most severe is also Staphylococcus aureus, and that causes acute type of infective endocarditis. In children, as well as subacute endocarditis, the commonest cause is Streptococcus viridans. Then we have prosthetic valve endocarditis. In that group, overall most common is Staph epidermidis. And if they ask the question, early onset endocarditis, that is also staph epidermidis, but if it is late onset, the answer is going to be Streptococcus viridans. And for IV drug abuser, it is Staphylococcus aureus again. That is the point. Okay, all these are different type of questions which can be asked for the exam, and I'm sure it can be repeated in the upcoming exam also. So you should definitely make a note of it. Clear? Okay. So talking about the features of this particular condition, of course, you will definitely get a fever. Without any doubt, there will be a fever. Okay. And next thing, see, very simple. We were talking about the vegetations, right? So think like this. These are the mitral valve which I'm talking about, and these are the vegetations, right? These are the vegetations. Now, tell me whether these are like very, very fixed vegetation or a very friable vegetation. Means they can be easily detached or not detachable. They are very, very friable vegetations. They are very friable vegetation. Friable vegetation means they can be easily detached. That's the point. They can be easily detached from that area. So think like this. As the blood is flowing, what they will do? They will detach from the mitral valve and they enter into the left ventricle. And from the left ventricle, they can enter into which part? They can enter into the aorta. And that aorta, through the aorta, it can enter into the systemic circulation systems. So think like this. This is the vegetation which is coming out into the aorta like this. It is something like what? It is something like an embolus, correct? Something like an embolus. So what happened? This embolus can go to different system and can cause different manifestations. This is what we call it as embolic phenomenon or the vascular phenomenon, because that is going through the blood vessels like aorta and the systemic blood vessels. So what are the problems it can cause due to embolic phenomenon? So think like this. It is going to go through a small artery. What it can cause? It can occlude the small vessels. It can occlude the small blood vessels, correct? It can occlude the small blood vessels. So what problem it can cause? It can cause a infarction. For example, it can cause infarctions in different organs. In the brain, it can cause an infarction and it can cause a stroke-like manifestation. So in the brain, it could be a stroke as a feature can be present. Any other features can be present. It can be something like this. I'll just take up one picture. See this picture. So, yeah, this picture. What can you see is that it can cause some manifestations in the palm area like this. Any of you know what is the name of this called as? This is also one of the embolic phenomenon only related to the palm area. Any of you know? This is called as a Janeway lesions in the palm. This is called as a Janeway lesions in the palm. Please see here. Please, you can write that. Okay, these are called as a Janeway lesions, which are involving the palm area. Okay, and these are painless lesions. Don't forget this. These are the painless lesions. Then you can also have something like this in the fingernails. I don't have the picture, but it's something like this in the fingernail area and all. You can have something like small hemorrhages like that. Something like small streaks like that. What do you call it as splinter hemorrhages? Splinter hemorrhages. Something related to the fingernail area. Fingernail area. All these are the embolic phenomena. Okay, all these are embolic phenomena. Something like the fingernail or the nail bed area. Actually, we call that as a nail bed area. Okay, so if you see through the nails and all, you can see some small red spots like that. These are the hemorrhages. Okay, right? So these are all the embolic phenomenon or the vascular phenomenon which occur. Second thing, what can happen is immune complexes can get deposited. So you think like this. This is the embolus or the vegetation which we are talking about in the circulation, right? Think like this, the embolus or the vegetation. And this embolus will be treated like a foreign substance. And against the foreign substance, what the body will produce, antibody will be produced. Or think like an antibody is produced against the antibacteria, something like that. And these two join together to form the immune complex, correct? These two join together to form the immune complex. And that immune complex can get deposited in the different parts of the body and you can get different manifestations. Any idea? Again, taking it back to this picture. Can you see in the tip of the fingers, these areas, you can get the red spots. That is also due to infected endocarditis, but it is due to immune complex deposition. Any of you know what is the name of this called? It is called Osler's nodes. This is called as the Osler's nodes. These are present in the tip of the fingers. Don't forget this. Previous one I told you, Janeway lesion, that was in the palm area, but Osler's nodes are in the tip of the fingers. And very important, they are painful conditions. They are painful conditions. Very important. I'm putting a star there. Okay, they are painful conditions. Don't forget, Janeway lesions are painless conditions. Janeway lesions are painless conditions. Okay, right. That is one thing. Next thing, in the retina area, you can see here something like the pale area. Can you see that this is a pale area like this? And surrounding that, you are seeing a redness. This is called as some spots. Any of you know what is the name of this called? It's called Roth spots. It is called Roth spots. Roth spots. Okay, red area surrounding surrounding a tail center. Okay, that is called rod spot. You can see that in the retina. That is what you can see them in the retina. Okay, they are called as the rod spots. And third thing is that in the kidneys, the immune complex can get deposited, and you can get what? Glomerulonephritis. Glomerulonephritis. Now, I want you to answer one thing. In this condition, what will happen to the levels of C3? Suppose you have this patient with glomerulonephritis in infective endocarditis, and you're checking for the C3 levels. What will happen to the C3 levels? Simple question. Whenever an immune complex is getting formed, the C3 will be deposited in the immune complex. So whenever a lot of immune complexes are produced, what will happen to the level of C3? It would be low C3 levels. Very important MCQ question. This condition is characterized by low C3 levels. It's an important question, previously asked also. Okay, it is low C3 levels. Are you able to follow? Right. So these are the immunological manifestations due to infective endocarditis. Other manifestation, quickly I will write it. One is splenomegaly, can be a feature as a part of infection itself, it can occur. And one more is finger areas, you can get clubbing. Something like the enlargement in the finger area and all. I think all of you know what is clubbing means. That is what it is. Okay, right? Something like bulging in the finger, end of the fingers and all. You can see something like the bulging. That is what we call clubbing. So these are the different set of manifestation in case of this particular condition of infective endocarditis. Of course, fever will be present. Along with that, you get immunological manifestations and embolic manifestation. And last would be the other manifestation, especially in that group. Splenomegaly is important. That's what you have to remember. Are you able to follow this? So that is about the features of infective endocarditis. And to diagnose infective endocarditis, we use a criteria. What is the name of the criteria I have written? Something called Duke's criteria. Something called as a Duke's criteria. With just like any other criteria, you get major criteria as well as minor criteria. Major and minor criteria. Okay. Major criteria are the ones which are definitely very important. What is that? One is blood culture. Can you see that? One is blood culture. Of course, it's an infection, so you need to have blood culture. But please remember this. How many blood cultures should be positive? It should be at least 2 positive blood cultures. Very, very important. Not a single positive blood culture. So typically what do we do is, we take at 2 different times 2 blood cultures, not from the same area, different areas, we will take the blood culture. And both those blood cultures should be positive. So very important, it is not 1 blood culture, it should be 2 blood culture positive. What is the second thing you can see? Evidence of endocardial involvement. Of course, we are localizing the infection to the heart. So you should see something inside the heart. So what can you do? What investigation you can do to look for endocardial involvement? You can do the echocardiography. And in the echocardiography, what are you going to look for? Of course, vegetation. These 2 are the major criteria. Okay, one is blood culture. Again, next one is the evidence of endocardial involvement, like vegetations on the heart. Other things are minor criteria. For example, there are 5 minor criteria I told you. What is that? Predisposing factors. For example, the patient is having a mitral stenosis or a rheumatic heart disease. That can be a predisposing factor. Second, of course, fever should be present. What is that? Temperature more than 38 degrees centigrade. Third is the vascular phenomenon. I have told you what are the vascular phenomena, like Janvier lesions, infarction in the organs. All these things are vascular phenomena. You can also have embolic phenomenon, or immunological phenomena. Like for example, what is the immunological phenomenon? Oscillus, modes, rod spots, glomerulonephritis. All these can be there. And microbiological evidence. See, already I told you microbiological evidence in the form of blood culture. Here, it is something like the other way. What is that? Blood culture, but a 1 positive culture. Instead of 2 positive cultures, you are getting a single positive culture. That is called minor criteria. If 2 cultures are positive, then it is directly major criteria. But if only 1 culture is positive, or something like unusual organs like ascites and all is present, then it is a minor criteria. That's all. Okay. So just remember, whichever is not satisfying the microbiological evidence of major criteria, I will put it under the minor criteria for microbiological evidence. Now, what is the criteria for diagnosis? How many of this criteria should be present? Please remember this very, very clearly. Okay. If you can remember Jones criteria, what did I tell you? What did I tell you for Jones criteria? Can you recollect? Anybody can recollect for Jones criteria? How many I told you? The Jones criteria also had major criteria, minor criteria, and also. Can anybody recollect? Just looking at the answers and if you're typing it. How many I told you for Jones criteria? Yes, of course. What is that? 2 major criteria, or 1 major plus 2 minor criteria, or during recurrence, I told you even 3 major criteria can be taken as an evidence. However, for Duke's criteria, it is slightly different. What is that? You should have 2 major criteria, or 1 major plus 3 minor criteria, or 5 minor criteria. All the minor criteria are present. Then also you can take it as a criteria for Dukes. Okay, in infective endocarditis. This is what you have to remember. Okay, so please do know about this and try to differentiate and study what is the criteria in Jones and what is the criteria in Dukes, because in the exam hall you tend to get confused. That is why I'm telling you, clearly know the criteria for Dukes as well as major as well as the Jones criteria. How many major and how many minor should be present? That's what I want you to remember. Okay, fine. Okay, now moving on to the last part. What is the last part? Last part should be the management of infective endocarditis. Okay, management of infective endocarditis. Okay, of course, you're going to manage with antibiotics. That is what will be the treatment. And you have to give an antibiotic which will cover the usual organisms like Staph aureus, Streptococcus, coagulase negative Staph. All these organisms should be covered. So what will I do? I will give a combination of antibiotics, not just a single antibiotic. Now the recommendation is like this: penicillins. Some places they recommend cephalosporins also, but generally okay, penicillin plus aminoglycoside. This would be sufficient for most cases. But nowadays, you know that many of the Staph aureus which are encountered in severe infections are not just simple Staph aureus; they are MRSA. So which drug you have to add? You also have to add vancomycin. So this is a 3-drug regime which is now recommended: penicillin, aminoglycoside plus vancomycin. This will cover almost all the important organisms which are causing infective endocarditis. Any idea how long is the duration? That is also important. See, generally for infection, we say 2 weeks of treatment. But please remember, in this particular condition, okay, the antibiotics have to go through that vegetation area. They have to enter or penetrate through that vegetation area, and then they have to attack the bacteria. So it will take a long time. So the duration of treatment also will be for a longer time. Any idea how much? 4 to 6 weeks. This is very, very important. It is 4 to 6 weeks. This is important. So it is not the usual duration of 2 weeks. We have to give it for a longer duration of time, 4 to 6 weeks. And for prophylaxis, suppose you have a patient is having rheumatic heart disease, and we know that patient can develop infective endocarditis. So, for example, the patient is going for a dental surgery or a dental extraction, tooth extraction procedure, something like that. They send you a reference. For example, we are in a medical college hospital, where there is a dental hospital also nearby. They send the patient to the medical OP, writing like this: this patient is going to undergo tooth extraction, and this patient is having mitral stenosis. Kindly advise on the prophylaxis for this particular patient. Because what happened during the time of dental extraction or dental surgery and all, lot of bacteremia will occur from the mouth area. The bacteria can get into the bloodstream and can affect the heart also. So what do we do before starting the procedure? Roughly around 30 minutes to 1 hour before starting the procedure, we will give 1 dose of an antibiotic to decrease the occurrence of bacteremia during the procedure. Any of you know what is the antibiotic we use? We use a single dose oral. Which antibiotic? Any comments? Which antibiotic? Amoxicillin. We use a single dose of oral amoxicillin for prophylaxis purpose. This is one of your previous year questions also. Okay, so that is what it is. Single dose oral amoxicillin as a prophylaxis before procedures you can advise. I hope you are able to follow this. That will be about the discussion of infective endocarditis in children. So some of the important points which you should remember are: overall most common organism is Staph aureus, but in the children it is most commonly Streptococcus viridans. Staph aureus generally causes acute endocarditis, whereas Streptococcus viridans causes subacute endocarditis. Common features would be fever. Along with that, you get embolic phenomenon or immunological phenomenon. Along with splenomegaly, you get. And for Dukes criteria to diagnose this condition, don't forget 2 major or 1 major plus 3 minor or 5 minor criteria also will be sufficient. Always with the combination antibiotics you have to treat it. But don't forget, it's a very tough infection to treat. So that is why the duration of antibiotics also 4 to 6 weeks. I hope you're able to follow this. With that, we will have the lunch break as of now. Okay, so this will be the lunch break now. So time is around 2 o'clock exactly. I think 45 minutes or 50 minutes. By the time we should be able to resume. So by around 2:50, I will start the class. Is that fine? All right. Okay, fine. So we will have the lunch break. Thank you.